Hello.
Hi.
Yeah. So, will you introduce all the three speakers yourself? I mean, the third.
Yeah. There is Sanchita. She will do it.
Okay, like yesterday, na? Okay. She is in. She has logged in, I think.
Hello, sir.
Hi. Good evening.
Good evening, sir.
Distributor বন্ধ থাকে না ঠিক আছে ঠিক আছে
How many logins were there yesterday? I found it something around 90 when I saw.
yesterday attendees
Yeah.
Total attendees including the Zoom and all was 110.
Oh, fair enough. In all these.
Sunday it was slightly more. चलो जिसको interest है.
Hey, airway 100 plus is quite good, na?
Because it's not bread and butter surgery.
That's right. Those who are interested in airway will come and join.
Right.
But one thing, what I was telling Vishwajit, see, 20 years back, as FES was growing in all parts of India, so I went to Dr. Kirtane's place to learn FES. That was in probably 2001 when I was doing DNB. Now, probably airway is in that stage right now because more and more people have started showing interest in airway. 5-10 years back, airway was not this much. There was not much discussion about airway surgeries and all this. So it is, what's the time?
15 minutes left.
Yeah. Shashi should be here. He's not here. Is it raining very much in your place now?
It's raining. There's a lot of flood now.
Yeah. That's what we are seeing it in the. I mean.
Presently, we have more deaths because of flood than due to COVID.
I'll just take a phone call.
कैसा है जर्नल का सिचुएशन कैसा है?
Journal ka situation, तो अभी it is late by 2 weeks time due to this COVID thing. This issue will be coming out by say 7 days. We got the
articles.
Yeah. 5-6 articles we have got. The editorial is there. Should be out by 7-10 days. Just it was to come out in the last week of June only. Okay. But what happened, the JP guys, they had their office closed due to this COVID thing a couple of weeks back.
Everybody's facing this.
Yeah, I missed out something important. You're writing a book, Sumitra?
No.
He's the editor of our journal of
It is our journal, sir.
Oh.
The IJOPL, that is our APSI journal. This Association of Surgeons India's journal. Presently, I am looking into it. I am the editor now. So, sir, I will request you to send any important cases or papers if you want.
Oh, definitely.
So,
just tell me the expansion of APSI.
Expansion means
the Association of Phonosurgeons of India.
Oh, phonosurgeons. Okay. Slightly outside my area of knowledge. But we have some things in common. We are trying to study speech after LT plasty.
Yeah. But sir, recently what has happened is phonosurgeons, even though the name is still stuck, we have a separate session for airway nowadays.
I know.
So swallowing airway and voice, 3 separate
Okay, okay, okay,
In the
Though
okay,
it
journal at the
started as
advantage, it's an open access journal. So
okay.
the hits are much more.
Wonderful, wonderful,
The open access.
wonderful. You
it is
know,
IG.
the call I got now,
Yeah.
very interesting. I'm just looking for the WhatsApp which just came in.
Yes.
Just give me a second. This is a 2-day child, Pierre Robbins, who was intubated and has got a peg, and the bougie is gone to the esophagus. And it's a 2-day child, so it's going to be really difficult to take it out because of the size issues. I don't know. Can I? Is it showing up?
Yes, 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 I
Yes,
can
yes,
see.
we can see.
Ah,
We can see that. Yeah.
Yeah. So, Gautam and Sumitra, I've been very lucky here. So, anything that happens in the neonatology or these areas,
you,
they get in touch with
we are
us.
quite lucky about that, sir. We do not get that many cases in Calcutta also.
Yes, and the reason why, one reason, of course, is not that we are the most skilled, is also when we started our center almost 19 years back, I was speaking to my pediatric surgeon colleague. I said, what is this? We're going to do 2 cases in a year, we'll never learn. How are we going to manage this? He said, don't worry. If you are really interested, start doing free. Then we started doing free, but we found the hospital bills were so high.
Yeah.
Then that is when I started collecting money, and
Yes.
my patients were so good. I think I've told you earlier also about 70
Yes, yes,
lakhs
yes.
I put in the thing, and that is, as long as that lasts, we can manage. So,
Yes.
because it's very expensive, this ICU,
Yes.
PICU, can't blame them. You see, they have to maintain quality. So all my colleagues work free. My hospital gives me free bed. In spite of that, expendables cost money. So that is the
Yes, because
situation.
I also sir, I work in a hospital in Calcutta which is run by the monks. That is a
Ramakrishna,
Ramakrishna.
no?
Yes.
You're a privileged man.
So that is the place where I cannot do the pediatric cases there. At least the adult cases, the resection anastomosis, it is much
Right,
much much less than a corporate.
right,
So
right, right.
one resection in a corporate will cost them something around 4 lakhs, 3.75 to 4 lakhs. And there it comes to something around 50,000, 60,000 like that. So that way we can manage the adult patients there. Not many that we see because we have just started airway a few years back in this eastern India, and nobody else is doing in that way apart from Gautam in the northeast. So people have started
Yeah, yeah.
knowing that we have started.
There is so
So
much
I
of
say to
clinical
others,
material. So much of clinical
yes,
material. So
that's
this
right.
baby is only 2 days old. So we're just trying to figure out whether we can use a rigid esophagoscope. Otherwise, we're going to use a flexible esophagoscope, which is meant for pediatrics.
Yes, yes.
So in fact, Deepa has just rushed to the hospital.
Okay.
We were waiting for the COVID test. That is another headache now.
Yes, yes, yes.
Otherwise, we would have done this about 3 hours back. The test they
Mm.
said will come now.
Waiting for the
So
test reports to come.
yeah, I told her that I'm an old man. I'll sit and watch Gautam Count's thing. You go and so she's going to do that case. And luckily, she's very enthusiastic, as Gautam has meant her, acquainted with her. So she's going to tackle this case. I hope they take it out. The only worry is upper esophageal sphincter sometimes can, make it difficult to pull it out. In
That's
such a small baby, 2 days is.
yes, 2 days is a pretty thing,
Yeah, yeah, that's good.
pretty small
We
child.
had one more case of a Pierre Robin like this, where we this kind of a bougie or what, it tore the esophagus while attempted intubation. So that was actually part of an exit procedure. So we quickly did a
Oh,
tracheostomy on the table. So that was another one. So crazy, all kinds of things happen.
yeah. Yes, yes, yes. Wow.
Hi, good evening,
Great,
everyone.
great to learn from you, sir, of all these experiences.
Hey,
They
no
will
problem.
definitely help
And
out.
Sumitra, we're going to have a big one in September. I'll give you a warning.
Okay.
It's going to go
Yes,
on.
sure, sir. That
It's going to go on for 4 Saturdays. It's going to be 3 hours each. And it's going to be from the best people in the world, all over France, people whom we have not heard, onwards. It's going to
okay.
be this thing for about 40 countries. So people like you, I'm sure,
Okay.
you know, to hear these people is
Yes,
difficult.
just send
Yeah,
send
yeah.
us a thing, so we will just
Yeah, yeah. 22 people, 22 of the speakers, including Mike Rutter, have signed up. So we're
Yeah,
getting, yeah.
that will be a
So,
very big show.
yeah, yeah, big show. So what we are doing now is kind of a, you know, we're trying to learn the ropes and seeing how Gautam's program is going on very well. So, you know, so many people are interested, and that
Yeah.
kind of infects you with enthusiasm. And so it's really nice.
Within a few seconds, we are going for live.
I just
Counselor, what about Sasi?
I just talked to him. He said, I'm entering in a minute.
Okay.
Arpit.
Good evening, sir.
Yeah,
Good
yeah.
evening, sir.
Arpit.
Hey,
Hi,
Hi, Soumitra.
yeah,
hi,
Arpit,
Arpit. Good evening.
Arpit, I was talking to Dr. Kirtane today.
Oh, sir. Yes, sir.
So he said he's our golden boy.
Yeah.
It's like he's like a father to me. So
He's been
Arpit, you got your laptop on?
yes, sir.
Yeah. Just in case, I told Shashi to keep a couple of videos. Like we do not have, like I'm speaking web, but we don't have open surgery for web. So if you have got, you just keep it around. If Shashi does not have, whatever you look at the talks, if you
Yeah, sir.
there's one video which you can share, because Soumitra, I forgot to tell him earlier.
Yeah.
So if you feel that something has not been covered, like we did yesterday, that will be better.
I have a very interesting. वैसे तो Vishwa is going to cover the endoscopic, I think, laryngeal cleft also.
I have told Shashi he might have brought everything, but I'm just telling you as a backup.
We have a series of 10 cases, clefts.
Oh, sir.
Each one managed slightly differently. One, unfortunately, just before our workshop expired in Indira Gandhi Hospital, because we thought we'll have it during the workshop. Because of the COVID, it got postponed. So there are a couple of lessons. One was attempted robotic.
Really?
So, yeah. So what I'll do is, Gautam, if I have your permission, let us see, because like Deepa's right now with that foreign body, the bougie in the esophagus.
Yes.
When she comes,
Yes,
if there is time, without overlapping on anybody else's thing, if there's something different, I'll just pop in between.
Yes, sir. Yes.
That's okay.
And sir, you have to tell Deepa to send her.
Yeah,
picture.
she'll do. Yeah,
Tomorrow she will be giving her a slot tomorrow.
sure. She'll do it today.
So
Sanchita,
4 more minutes.
Yes, sir.
Sanchita, you are ready?
Yes, sir.
Shashi has still not entered. I talked to him. But
Please.
late.
Shall we wait for Shashi for a couple of minutes?
We are,
Yeah.
I think
There's still time actually. 2 minutes.
yes.
We'll wait.
2 minutes to go live.
So that's what I'm saying. So we can
sir,
start.
Counselor, so have you talked with Raman sir regarding what my radiology things we have discussed in the morning?
Yeah, I told him Deepa is coming in with a 10-minute stop on ultrasound of the trachea.
Okay.
Is it today or tomorrow?
Tomorrow.
Yeah,
tomorrow.
it's tomorrow.
Because we have kept one session for air radiology. Sumitra,
Yes.
let's see, because it's a new thing. I have not seen that much of experience of air radiology also, but
Yeah.
Today the talk should be a little long. I mean, the discussion should be a little long. Most what I'm expecting.
Yes.
The 4 surgical topics actually. So
Just waiting.
Arpita, I heard your wife is also a very accomplished ENT surgeon. Yeah,
yeah, sir. She is into head neck. She is
wonderful.
faculty at Tata Memorial, sir.
What's her name?
So you get a lot of tracheal cases, right?
Not really. We don't refer cases to each other. She's Deepa Nair, sir. Deepa Nair.
I heard her name. Yeah.
So actually, she happened to work with Dr. Pankaj Chaturvedi and Prathamesh Pai. So she got trained in skull base as well as She is organizing the oral CA course every year nowadays.
That's why I heard her name.
कितना मार्केटिंग कर लिया अभी तो आपका?
Thank you, sir. Thank you, sir.
क्या हो गया शशि?
Sir, if this lockdown, this Corona thing would have been like maybe 2 weeks later, so we could have been like able to attend your workshop this year.
Yeah, very sad it is.
You were really,
21,
yeah,
21 cases we had, you know,
you were really
all
looking forward to it,
varieties.
yeah.
There were 3 clefts, 2 of which we have done recently. Means, I mean, before the Corona became bad.
Hello,
Yeah,
Dr.
And it's been a learning experience.
Welcome, Dr. Shashi. Voice is not on. Oh, he's in the hospital, I believe. Probably doing. Hi, Dr. Shashi. Can you hear? Your audio is off. Yes. Can you hear me? Yeah, no, we can't hear you.
Now
yeah,
you
he's,
hear me?
yeah.
Hi.
Hi, Shashi.
Hi, good evening.
Hi, Arpit, how are you?
Fine.
Good evening, Dr. Sashi Shobitra here.
You are in Shashi. I think we can get along. You are in the hospital.
Yes, we are still in the working time, Vivi.
I think
Evening
Shashi is the only guy who is really working throughout this COVID times. Rest everyone is like sitting quietly at home.
clinic.
He's not been selfish. He's teaching how to work in COVID times. He's trying to teach people how to work in COVID times.
Yes.
Anchita,
Yes, sir.
Dr. Raman is here.
Yes.
Hi. Oh, okay.
Good evening, Sasim. Hello,
Hi,
sir.
Dr.
We
Gogol.
can start now. It
Yes,
is already live.
Hi, Sashi.
Hi, sir. How are you?
Doing fine, thanks.
Sansita,
Yes, sir.
please start the proceeding.
Yeah. Okay. I, Dr. Sanchita Kalita, on behalf of GVSB Group and Pediatric Airway Center, would like to extend a warm welcome to all respected delegates assembled today on the third day of this live instructional web series on Pediatric Airway. We are very proud to have amongst us Dr. Shashidhar Tatavarti as our resource person for today's session. With enormous experience in handling challenging cases, he is currently working as a consultant and head in the Department of ENT and Head and Neck Surgery in Artemis Hospital, Gurugram. He is a foreign medical graduate from Chicago, Illinois, USA, and completed his post-graduation from Lady Hardin's Medical College with training in pediatric ENT from Cincinnati Hospital, USA. He is also a clinical visiting fellow there. His clinical interests include airway reconstruction, treating swallowing disorders, sleep surgery, and pediatric ENT. He is a passionate learner with a flair for research and academics and teaching. Welcome, sir.
Thank you. Thank you. And I'm honored to be here amongst the august audience here and very learned co-faculties. And I think we'll have a great interactive session talking amongst each other and learning from each other.
Hopefully, sir. I also have the pleasure to introduce Dr. Soumitra Ghosh, sir, as the guest faculty for today's session. He is the Associate Professor in the Department of ENT and Head and Neck Surgery in Vivekananda Institute of Medical Sciences, Kolkata. Dr. Soumitra Ghosh, sir, is the consultant in the airway unit of AMRI Hospital. He is the editor-in-chief in the International Journal of Phonosurgery and Laryngology. Welcome, sir.
Thank you very much. Good evening, everybody. First of all, I would like to congratulate Dr. Count and his team for this enormous initiative of this series of webinars. We're having a lot of webinars, rather hundreds and thousands of them this during the COVID and the post-COVID time. Definitely, airway is something which is picking up as a Gautam Count. 20 years back, as FES was something which was growing in ENT when we trained ourselves in FES in the late 90s. Now, airway is a big idea. There are pockets of airway hospitals and people doing airway surgeries, but now we have got so many webinars and so many people are showing interest in airway. and all of us are learning from our colleagues, from our seniors, and this is a great effort on their behalf, and I would like to thank them. So we are waiting for a great interaction, and learning session in coming 2 hours. Again, thank you very much, Dr. Khan. And I think without much delay, we straight away go to our sessions today. I think we have got 3 speakers. Over to Dr. Khan.
Sanchita, you have anything to add?
I wanted to introduce the in-house faculties, all of them.
Okay.
Brief introduction. So we have as in-house faculties Dr. Gautam Khan sir, Dr. Biswajit Gogoi sir, and Dr. Keshavananda Kuar sir from the ENT group, and Dr. Parikshit Hazarika sir from the anesthesiology side. A gentle reminder for all the viewers to type their questions in the chat box. All the questions will be discussed at the end of the sessions. And if there is any input from our respected resource person or guest faculty, then it can be entertained after each speaker. Now, without any further delay, let me introduce Dr. Gautam Khan sir as the opening speaker for today's session. He'll be speaking on congenital laryngeal web.
Yeah. Thank you, Sanchita. Good evening, ladies and gentlemen. First of all, let me thank Dr. Sashidhar Tathavarti from Gurugram. As you can see, he's still in his OT scrubs and a busy man, but still making time for us. Thank you so much, actually, Sashi, for being here, because would like to have your inputs, because you have a lot of great experience in pediatric airway management. And of course, my younger brother, Somitra, thank you for being here. We will take the inputs from you as well. You have got some good exposures. And we are thankful to Dr. Raman always, because he's been there from day one, stimulating us. And Sashi, probably you were not there in the first day. Let me just repeat for people
Yes.
who are not there. We are a team, actually, we are not a team of experts. We are a team of, you can say, a passionate group of people working in the pediatric airway, not very experienced, but still then we are trying to popularize the subject in our part of the world at least, and have inputs from everybody so that our knowledge increases and we can share our experiences as well. So today, I start the proceedings with congenital glottic webs. I hope my slide is visible.
Yes, sir.
Yes, sir.
So congenital glottic webs are quite uncommon, about 5% of total congenital anomalies. And the embryology, it could be due to it is usually due to a failure of complete recanalization of the larynx during embryogenesis, and may result in a glottic or rarely a supraglottic web between the 8th to 10th week of embryonic development. Majority involve the anterior glottis, fusing the vocal cords along a variable length part of their length. Most severe forms of glottic webs are associated with a cartilaginous subglottic stenosis, and association with microdeletion of chromosome 22q11, the velocardiofacial syndrome in some cases has been seen. This is something I picked up from 2 books, from Monier's book as well as from the Scott Brown the last edition, that we have to differentiate between a web and a synechia. Web is congenital membranous stenosis and synechia is the acquired, but usually we use it quite interchangeably. Whenever we have a psychiatric addition between the vocal cords also post-intubation, people tend to use the word web most of the time. Anyway, let's look at the Cohen's classification of glottic webs. So most of you might be aware, but the Cohen's classification, the type 1 is less than 35% of glottic length. So we can take it about 1/3 of the glottic length. And here there is no subglottic extension, as you can see on the slides below, the pictures below. In the type 2, we have a length of 35 to 50% of the glottic length with minimal subglottic extension. In type 3, you have a 50 to 75% of the glottic length with significant anterior subglottic extension, and there might be some cartilaginous element as well. In a type 4, which is 75 to 90% of the glottic length, there might be a small slit of a small opening below with severe subglottic extension, and definitely there is a cartilaginous component. Well, these children may present with inspiratory, will usually present with inspiratory stridor, the voice is affected, the weak, high-pitched, squeaky voice, the cry is less. In fact, all of the cases that we had, the first case actually did not come because of a respiratory problem. It came because of a voice. The child was not having a proper voice. That was the reason actually the parents came. A weak cry from birth is something which is seen and recurrent croup in infancy. The investigation that we need to do, the TNFL, is to see the vocal cord mobility, the rigid rod length laryngoscopy for degree of subglottic extension and the subglottic lumen. It may not be possible in all the cases, and suspension microlaryngoscopy to palpate the web for cartilaginous component, X-ray or CT for craniocaudal extension of the web. Well, this is a picture of a web where you can see there's a very small opening. You may not be able to pass even the rod lens through this small opening, but TNFL, I'll stop this video for the time being. Let's look at this. So you can see there's a web which is almost a type 3 web. There's a small opening below. Normally, when we see a pathology, we try to go down and try to see what is below, but it may not be possible in all cases, especially in cases like this, where the opening is very small. It may not be possible to go down and to see. So we try to have a closer look. I put this, the other video down, that small video, because here sometimes you get confused about whether it is a web or it's a subglottic stenosis in the true sense, because it looks like a subglottic. There is definitely subglottic element, but you can call it a type 3 web also. What happens, what are the treatment options for us? In type 1 and type 2 actually, in type 1 mainly we can observe because it's not producing too much of symptoms, and we can wait for the child to grow. CO2 laser division with a mucosal flap is something that is done. We do not have experience of that. If one of our experts has, we'll be happy to see that. Type 2 CO2 laser division with endoscopic kill, we have done that, but I'm sorry, I won't be able to show you a video of that. We had done it on an older child for voice problems. Type 3 division with endoscopic keel or open surgery, and type 4 definitely tracheostomy would be needed with a 2-stage PCTR or LTR with temporary stentings. So this is a diagrammatic representation of a type 1 where we can have a mucosal flap which has been turned on itself so that you can cover it. We are covering the raw area on one side, so there's no chance of the raw edges meeting together again and forming a web. So let us look at this video of a 10-day-old baby presented to us with respiratory distress, and this was this web, and we did this surgery with cold instruments. We did endoscopic, we did not do an open procedure. Theoretically speaking, this should have been a patient for an open procedure, because you can see it's a type 3, almost type 4 you could say. There's a very small opening. In the tracheostomy had to be performed in this patient. So after the tracheotomy, we used the scissors and stayed in the midline and divided the web slowly. We take you a little ahead. Yeah. So as we go down, you can see the tracheal lumen. This is below, and this is this sort of a boundary wall in between. You palpate, you see what's going on, and there could be some bleeding. We had to pack and wait for some time. And now as we go down, we can see the tube coming up. So the lumen has been restored. The things are looking a bit rough and ragged edges, but this is a very much magnified view since you're looking with a scope which is quite inside. So how do we prevent restenosis? What we did is actually put a silicone sheet over a feeding tube, infant feeding tube, and then we pulled it up. We passed the needles. We did not have a Lichtenberger burger needle, so we passed the needle from outside below the larynx, and we passed a proline suture through the needle, which was taken out outside. Then we, sorry, sir. Yeah. So we have another needle passed in front of the vocal cords, and again we are passing a suture, but the same suture, actually the two ends have been passed out and the stent with the tube is inside. Now we have somebody is pulling the sutures up, putting a traction, and we are pushing the tube along with the silicone sheet into the lumen of the larynx. So once this has been snugly fitted, we did not make a skin incision to bury the stitches. What we did is actually we had taken the we had tied the sutures again over a silicone sheet on the neck, on the skin, over the skin to keep it in place. So, this is how the sutures, this is a schematic representation of the whole thing. So the needles were passed below and above the heart cartilage, and then we pull the stent inside. And this is the stent which has been taken out at 3 weeks. And this is the child. This is actually a picture from today. We had, I asked Biswajit to call them up, and now the child. This is
কি করব পিঠি দেব
voice is a little hoarse, but here you can.
2 3 start গো দাদা জুড়ে দাদা পাপা.
Thank you very much. So main issue is respiration, breathing, and restoration of the airway and voice. So you can see the voice is also quite bad, quite okay now. In spite of during the surgery, we were also worried the edges were looking so ragged and all that. But healing in a child is actually stupendous when you keep the stent for a proper period of time. Thank you. I end my thing here. I'll end my share. I leave it to Dr. Tatuvarti now for his comments, expert comments.
Yeah, I'm no expert comments. You did a beautiful job, and so heartwarming to see the kid coming back. So this, like I said, is I'm just like one of you that we've learned our share of problems, and over the years try to evolve, because there are no great teachers who will come and teach you. So whatever resources you can find from the nearby friends and literature, we all learn. So because you asked me to make the slide for the web, so I'm just sharing my slide here, just point wise on two things which we do sort of differently over the years with hit and trial. One was the biggest. Can I share my slide here? Yeah.
Yeah, Biswajit, have you made him
Yes,
a host?
yes. Already I have made him. You make you see as a co-host. Can share.
You can share. You can
Yeah,
share.
yeah, we can see. We can see. We cannot
I'm,
share.
I'm
slide.
sharing it. Yeah.
Your slides are coming. Okay.
Yeah, it's there.
So the cheapest and the best material we found for the keel, laryngeal keel, that's the word we use, is actually the blood donation bag. several reasons for it. It does not tear off. You want a thin material, but when you take sutures, it should not cut through. So we tried with 1 mm silicone sheet. Probably 3 mm is a sturdy one, but it compromised the glottic airway. And suppose you did not have to do a tracheostomy, the child coughs and it irritates the throat very much. So this is the best material. And one bag which probably costs you 400 to 800 depending on where you are will give you at least 30-40 laryngeal keels. So this is the shape which we use, like a t-shirt. And there are one hole and the other hole down, and exactly like what you have done, we go through the needle and fix it there inside the larynx. So just to see, so these are the types of the webs which I wanted to uh, show you. I'll come back to that stent type. So the biggest telltale of the web is actually the voice. If the child has a poor voice and is stridor, uh, web is one of the most likely diagnoses. And sometimes the web and stenosis go together. And that's what you need to really palpate and break the posterior web and try to see if there's a stenosis or not. Because if there's a grade 4 stenosis, like what you said, the approach entirely changes to a PCTR or a LTR or a different mechanism. So this was a web which we broke, and then we saw that there's a subglottic stenosis, and then we didn't try to do anything, went into open surgery. Now I'll come to the laser part later. Now coming to the keel, so once you design the keel, go down and actually size it. So this is, I'm trying to see the keel, the vertical diameter, how it should be, because if you see here, I'll pause it, there are a lot of raw areas here and there. So raw areas in the subglottis, in the supraglottis, on the vocal cord. So the vertical length should be good enough that it is covering all of that, but should not be projecting. So that's why the t-shirt shape was very helpful, that it doesn't block much of the airway. And if you see this, the thickness is not much at all. And once you size it and you trim it and everything, and this you don't have to really extubate it. You can do it on the tube while the patient is intubated, you can size it. Then you fix it with the sutures exactly the same way. So the two things which we do differently is the burying of the suture is always done in the below the skin. And this I learned from Dr. N.N. Mathur, who was one of the pioneers in the pediatric, because he used to bury it over a button. We used to do it. And after a week or 10 days or 2 weeks, it always used to get loose. So the problem is completely avoided when you kind of bury it under the skin and put around 30 to 40 knots with proline. So, and close the skin in the neck completely. So when you come later, you can actually palpate that there's something hard inside the neck. You give a 1 mm, 2 mm incision, open up that subplatysmal fascia and remove the sutures. So these skin infections from the outside neck and everything is much less if you bury it down. Because you were not using a stent as such, I think the approach which you used is absolutely all right, that you're using the feeding tube there. Uh, uh, but if you don't have a tracheostomy, we can't obviously use a feeding tube there on this part. Uh, the other thing which we do is what you exactly said, that bleeding and that uh, point where you want to cut little more, but your sickle knife is not good enough to cut through, and you are struggling to give pressure there, and that's the area we actually tend to damage the anterior commissure. So over the time, what we learned is, once you make it, just intubate the child and put the smaller size of balloon there, and you can use a cotton. And when you inflate the balloon, it will shear as per your previous incision and open up the anterior commissure completely right up to the perichondrium. So this is a glottic web intubated. And the problem is we don't have many sizes of the balloon. I only have a 4 balloon, and the next size will go up to 6 or 8. And when you inflate it, some part of the tube also gets compressed. So what you need to do is put actually patties in front of the balloon so that it acts like a 5 or a 6 balloon. So that's how, even with one balloon, you can take the work of 3 or 4 balloons by putting patties there and then expanding the balloon. So this saves a lot of money, and also, doesn't require you to, get the new balloons every single time on that part. Now, when you put this stent, this is the OPD assessment. The child talks and it moves freely. So the chances of adhesions are considerably reduced. So this is from that blood donation bag stent. Okay, so it works quite satisfactorily. We possibly have about 6 cases right now from the previous one. What other authors would do sometimes is actually they would use skin graft also if the raw area is more. I tried it using one. Uh, I could not really see a huge difference in the granulation or the healing rate. Some people actually put a lot of ointment pack, and they when they put a keel, they use the ointment pack there. Uh, but the most this is a video by Dr. Rakesh. I took the liberty of stealing the video and also not informing him. So, but that liberty I take with him a lot of times. So he does it very well. So this is under again TIVA, and it kind of really opens up well. I wish, we have a good CO2 laser, because the 3 different planes in which the cutting happens are entirely different when we use cold instruments. The epithelial layer, the muscular layer, and the lower conus elasticus. So it goes little oblique. So the voice results are much more better if you have a laser. But if you don't have a laser and you're doing under guidance with a cold instrument, instead of using a sickle, if you use a long bevel 50 number blade, it also works the same. Uh, in gynecology department or other thing, they have the handle of the blade which is much longer. Almost it comes up to 25 centimeter, very slender and thin. So I borrow from them, and in US they call it a beaver knife. In India, that's our beaver knife. Is just to use a long handle which will go through your DL scope, and you can actually use a 50 number blade to cut. That also gives a very satisfactory uh, results. We don't have the sickle knife is multiple attempts, different planes, but if you can make a 50 number blade to cut it, that's absolutely wonderful. It is okay to sometimes see it endoscopically and cut it from the external also. Do a laryngofissure. Uh, just expose the thyroid cartilage and cricoid and just make that cut with from the external while you're seeing it endoscopically. That also gives the exact division at the anterior commissure. That also is a very good method. So, yeah. So another thing which I wanted to tell you is certain times post surgery, glottic surgery and everything, you have a web which appears like this, and you really want to do a lot of surgery and everything. In this, just put a balloon and dilate it. The polyp is all water inside, and it just shrinks to a very small pedicle once you balloon it. And that's so easy to cut off, and you have a much bigger lumen with that. And lastly, only in one case, so this is a case where there's a web, there is a subglottic stenosis. Vocal cords are not at all identified whatsoever. It's like a complete thick scar tissue there, which is extending in any way. And the only place where the only surgery which will be successful here will be a extended PCTR. And this patient already had multiple surgeries before he came to us, and his problem was actually increased by the T tube. The T tube, which was put to treat his stenosis, was causing these granulations, and it converted the subglottic stenosis into a transglottic stenosis. So this is so although this patient has only one vocal cord, because instead of having two non-functional vocal cord, I decided that I should keep one vocal cord which is functional when you do a PCTR. So my cut here in this was not in the midline, as your reflex will be, but actually in the corner side, because I'm trying to make a lumen one side, and the other side is actually taken by the cartilage graft. So this functional vocal cord gave the child a voice and also the airway. So the rule that you always have to cut in the midline may not be always true. You may actually have to break the rule sometimes when you consider the voice and other things in the later part. That's it, sir. So I think we'll go for the next talk.
Yeah. Soumitra, do you have any inputs from your side before we go to the next?
Just a moment. Yeah, can you see me?
Yeah, we can
Yeah.
hear you.
Thank you, Dr. Sashi, for your excellent videos and tips. It was great learning. A few things that I just wanted to chip in is we should be very careful about picking up whether this is a glottic thing only or a glottosubglottic, because that entirely changes the approach to the patient. And based on that, you have to counsel the patients the way, I mean, the patient party about what outcome we should expect, because nowadays that's a big thing. You have to counsel the patient in a big way, and you have to give them the options, plan A, plan B, like that. Regarding the mucosal flap, I personally don't have any experience of mucosal flap in the pediatric group. I would ask Dr. Raman and Dr. Sashi if they have got any experience of the suturing the mucosal flaps in the pediatric, because it is pretty tricky about suturing with a 6-0 with vicryl down there, and putting 2 or 3 sutures. It's quite difficult. So, Dr. Sashi, do you have any?
So the first requirement with mucosal flap is actually you should have a good CO2 laser. If you don't have a
yes,
CO2 laser, you can't.
It's pretty difficult. Yeah.
Raise the flap. So I've done one case with Dr. Rakesh where we were trying to do it in everything, and it didn't really come out as the most perfect one, but it kind of worked. So if there is a case which has 2 or 3 revision surgeries has been done on it for the web, and that's the place which should definitely have a mucosal flap,
Yeah.
because there's no point in going and trying to stent it and do a 4th surgery on it without a mucosal flap. But for the first, or the second surgery, I don't think that's the only way to do it.
Yeah.
What Dr. Gautam showed is absolutely, it works well if you take a good care of the patient.
Yes. And one more thing is the most stubborn thing about the thing about these doing these stenos, I mean, these cases is the granulation tissue which develops after 3 weeks when you take out the kill. And that again gives rise to some amount of recurrence, whether they are clinically significant or not. So I would just ask you to highlight what is your protocol to take care of this granulation tissue when you take out the kill after 3 weeks.
So granulation tissue is when the tissues are very tightly packed, and it's actually a devascularization issue.
Yes.
It's like submucosal vascular hypoxemia is there. So when you use a very free key like the one which I showed, which is a very thin membrane and there's a good vocal movement, you don't really see those things.
Okay.
But if at all they come at, you have to be more aggressive with the granulation tissue, and you have to probably go back every week or 10 days and remove it. Then our the usual protocol, we say 3 weeks or 3 weeks. I would say just go back every 7 to 10 days, put steroid injections there with gentamicin or any antibiotic neomycin, and kind of treat it aggressively.
Two things which we follow is we ask the patient to talk a lot. I mean, they should not keep quiet. Even just after the surgery, they can speak, they shout, they sing. So we tell them you speak a lot so that to prevent these synechias or waves to come back. And secondly, you know that spirometry that for the to increase the pulmonary function. So we ask them to buy one. It costs only 200 to 300 rupees or something like that, and blow through it throughout the day, just to keep the vocal folds apart so that they don't get synechia. But even if with the best efforts, always you occasionally you come back with some amount of synechia, though they are not functionally that significant, or the patient may not even get bothered about the quality of voice. But when you put in a scope after 3 weeks, you see, again 20% has come back. So that's what that's my experience. And another thing which I have is regarding the incision and the blade, which Dr. Shashi said. I have got one beautiful long handle which I got from I got the idea from Dr. J.K.R. Menon when I was at his place 10 years back. There's one South Indian company or Santosh Surgical, I don't remember. The tip is the same, where you can put in a 15 blade or a 11 blade, and it has got a long handle which gives a sharp cut. Even for your microlaryngoscopic surgeries, if you don't have a laser, the commonest thing which goes blunt is your sickle knife, be it a otological surgery or be it a microlaryngeal surgery. So each time you can just change it, change a number 11 blade, which is available in all the OTs. So I don't have the picture right now with me, but it is available with some surgical Indian companies. Hardly costs you 500 rupees, and it's a very good thing. And I think that's anything Dr. Raman has to add up to this recurrence thing, how to prevent and
I
so.
just need to say how wonderful the videos were. First, Gautam's video, extremely good.
Yes.
The innovativeness of Shashi, I mean, his mind is always thinking, I wish I could borrow part of it for myself. The innovative use of that blood donation bag or whatever, it's excellent. Shashi, quick question. Did those children have any tracheostomy when these things are there? You managed without a trach?
Okay. So most of the cases.
Sorry.
Okay.
Yeah, go ahead.
There was only one kid which required a tracheostomy post-surgery.
Now, these are very small children with this stent, whichever you fashion, lying there, and without a trach. What is the...
so we don't do trachs, but I only had to do a track and post of day 3 of one kid because of the edema and everything. So now I'm not super confident that all kids can be managed without tracheostomy. I do agree sometimes you may be stuck.
No, but even one of your cases is managed with this. It's great news. I mean, because the airway is so small in these children. That is fantastic work. Now, again, very nicely highlighted by all three of you about the sickle knife business. It just doesn't work because you use it in one case, and if it is hard, it just doesn't work. And I think Shashi and Sumitra, both of you should take up agencies, one for the blade and the other one for the bag that you're using. I mean, I think you'll make more money than your ENT practice in pediatrics. That is one part. I think I'm going to ask Sumitra to tell me where you get it, because this is one problem that we feel. Then thirdly, regarding the stitch, it's extremely difficult to rotate that flap and do that stitch. I managed to successfully do it in only one case. It was in Hyderabad in the children's hospital. I did a workshop, and after 6 weeks, when people were, I insisted that the child be called and reviewed. You see, in government hospitals, you don't see the patient again. So fortunately, they said the child was doing well, but we don't have an endoscopic picture. And one more quickly, I know there's a shortage of time. This is for my younger doctors. After giving that slit in the web or whatever, you'll find a lot of mucosal tags. Don't go and pluck it. Every time you remove the mucosal tags, you're creating an injury. Okay.
Yes.
And we are doing exactly what Shashi was saying. After that, any residual thing, these balloons are beautiful, extremely good. And if you want to go again, and maybe you have to do it again. In fact, we have one child waiting because of the COVID. We have not repeated the balloon. We did the ballooning soon after the, after giving the incision, first with the laser. Laser is sometimes very useful because it is precise, but then some of us don't have it. And then the final cut, even there, I think you use with the cold cut, the final one,
Yeah.
to release it. Then use the balloon. I think it is extremely good. One last point was there was a child whom I think probably the child was slightly older, around I think 8 months or 1 year old, where we did the web excision and I lost the child to follow up. And when the child was 6 years old, he was sent from the Institute of Speech and Hearing from Mysore saying that there is a WEG, please go and get it operated. So I was very happy to see the child after 6 years all of a sudden coming back, because I remember the child, because the child had lost the mother during childbirth. So we knew about this kid. So we saw the child and we found that his voice was good. Then we found that this boy was playing, he was swimming. He was doing everything absolutely fine. Then I said, let me have a look at the larynx. Yes, there was a small bit of web there, but it wasn't coming in the way. It's important not to treat the web, but treat the patient. So it was a very happy feeling for me that. So the warning to people is don't go and do anything again. The larynx grows, and some of these things become all right over a period of time. Thank you.
Thank you, Dr. Raman. Thank you. I think we could have gone on and on. I find Dr. Vidyasagar has also joined, but we should pass on. I ask Sanchita to take over now.
Shall we move on to our next speaker?
Yes.
Yes.
See, can you off share your presentation?
Shashi, could you stop share?
Stop.
Yeah, sorry. My bad.
Sir, if you allow me, can I add few points before my presentation regarding the wave? Just 1 or 2 points. As Raman sir has said, we basically in type 1 or type 2, we should go more conservative way. Let this child grow. Basically, they come to the aphonia, and they maybe have exertional dyspnea, but that not much. Regarding the type 3, it's always a 3-dimensional. It's not a 2-dimensional. Or type 3 and type 4, there's always a vertical extension. That's we should remember. And third point I want to share here, the another Indian jugaad is I have learned from Kirtane sir. The implant sheet is a very the electrode sheet is a very good inert material, particularly from the decisioning, not from the nucleus or advanced bionic. Because basically decisioning one was a wider bore if you want a tubular stent. And third is, if look, most of the web patients have a aphonia. They don't present with a respiratory distress, still in a type 3 also. That's why we have a late presentation. They mostly come with their child does not talk. So we should not do too much maneuver because they have a distress with exertions. So we should not go for any kind of maneuver. It may be pre-op, it may be during operative also. That's why our first case we have experience that our anesthesiologist, sorry to say, Paul, has tried to intubate the child, but the direction of the extension, the vertical extension, is not anteriorly. It's always posteriorly in type 3 and type 4. Type 4 is a whole total closure in type 3. So if the curvature of the endotracheal tube, it always goes anteriorly. So it's very difficult to intubate the child. So it's better with a supraglottic airway, sedate the child, do track, and do whatever maneuver. If you spontaneously, it's okay. But if you want to take pre-op also for the later, like what Raman has said, it's very difficult to maintain stand with a, and then that things we should not maneuver larynx. It may go to spasm. That's all. So now I'll go to my presentation.
What it has said is very true. We had a real crisis on the table because the anesthetist insisted that I can intubate. Let me go.
Because he's seeing that's the whole of the laryngeal inlet. So he said that so I'll definitely intubate this child. When he tries to intubate, there's just bleeding, the patient gets spasm. Then after that, we have to perform emergency track. And the child was, there is total, then when we do track, there's no exhalation of the air in the track. Then we have to found it endoscopically that this is the trachea, because in a day's child, it's very difficult to get the trachea. Thank you, sir. Then I'll go.
So just to add on, over the years, we have taken over the intubation. If there's a difficult airway, the anesthetist just paralyzes or gives you sedated.
Okay.
Exactly.
And we take over, we see it under the rigid Hopkins, and we kind of put a tube on our own. So,
Uh,
because our magnification is much higher, and you can
Exactly,
actually
sir.
see what's
Exactly.
happening.
Yeah.
Exactly.
Exactly. Exactly. So there's people think that I can contribute, I can go into the lower area. Thank you so much. Then I'll go my own presentation.
Yes, sir.
So good evening, respected teachers and my dear colleague. My topic is on laryngeal cleft. By definition, it's defined as a craniocaudal slit defect of the party wall between the laryngotracheal airway and the upper digestive tract, basically pharynx and esophagus. It's a very rare condition, 0.5 to 1.5% in a live birth situation. And little bit of embryology. At around 4 weeks of intraembryonic life, there's an outposting of the from the ventral end of the foregut, which is we call as a respiratory diverticulum. If you see the picture, basically we take birth for having all this gut. This is a foregut, midgut, and hindgut, but the respiratory diverticulum appears at the age intrauterine life of 4 weeks. Initially, the diverticulum continues with the foregut. Later, two folds develop, which fuse in the midline to form the tracheoesophageal septum. This is the septum, or you can call it the tracheoesophageal ridge also, and which divides basically trachea, that's a windpipe, and the esophagus, the food pipe. These septums grows caudally and cranially, and basically the failure of the fusion of the septums gives to two situations. One is tracheoesophageal fistula and one is cleft. Cleft basically it's a cranial defect, and that's how it's in the region of the ENT. And I think most of the tracheoesophageal fistula is handled by the pediatric surgeon and not the ENT. So most of the child they present with cough with fits, and they also present with a cyanosis with feeding, and sometimes they may present with a life-threatening events. And there's sometimes they have a recurrent admission due to aspiration pneumonia. The presentation depends upon the extent of the cleft, but I want to share here is a different presentation. If you see this child was tracheostomized just after birth because of respiratory distress, and he has a feeding intolerance. After that, he has they tried food declination of the child, but issue with when they give the breastfeed, the patient has a developed respiratory distress. Then they put on the tracheostomy. This child was evaluated in a very good institute in India, and so in that sense, the child may present, if you not properly evaluated, the declination issue also. So this shows the child. If Joy Kumar Menon sir is here today, he knows this child. And if you see the child, I don't know why this child is 8 times bronchoscopy, fiber optic bronchoscopy was performed in one of the India big center, but the cleft was ultimately not diagnosed. But if you see the child, he has a telecanthus. As such, when I have gone through the whole slide, then I have found that he has a midline effect. Then when I accumulate all these findings in a Google, then I have found there's a called syndrome, BBB syndrome, 4B. Then this is called off-type syndrome. And the other syndrome associated with most of this kind of side is a polyester Hall syndrome. There is also vectoral syndrome associated, and also SARS association. Recently, we have experienced the non-syndromic, because every time we go to books, then I see the most syndromic things. We have not seen that what are not syndromic. Most commonly occurs things that's like tracheoesophageal fistula. I'll going to share in the later part of my presentation. And this is how, if you do the investigation of this kind of child, we have found there's a sign of aspiration, and esophageal spillover the contrast material in the as a whole airway, I'd say, as the picture shows, there's a contrast spillover. Fiber optic laryngoscopy, most of this time may remarks as normal, as I have mentioned at the previous slide. So well, it's not the thing of the airway center who was mostly doing the airway things, but there should be a very high level of suspicion during fiber optic lens. There's very small tricks is here. If you are doing a fiber optic laryngoscopy, this kind of file, what I did with the file, as my teacher counselor has given the whole file to look through all this previous video, then I did one thing. In my software, I just reduced the speed of the endoscopy. Then that's the way we can evaluate. That's why you have to see if in this kind of very interesting cases many times, not one times. Then I have found when I slow down the speed, when I saw the posterior glottic part, then I have found in fiber optic laryngoscopy, not I'm telling about the rigid one, then there's a big cleft posteriorly. That's how we can see in case of fiber optic laryngoscopy also. FIS is the fiber optic endoscopic evaluation swelling is the most physiological diagnostic tools, but it's very difficult in case of children. But many centers is now doing. We are also trying for FIS, but it's very difficult in case of children. So ultimately, the rigid telescopic evaluation with vocal cord separation is a gold standard to rule out cleft. This is the Benjamin and English classification. Here is a type 1. Basically, one is above the cricoid level. If you see, this type 1 is, if you see, the cricoid is intact, and it is above the cricoid. Type 2, there's a halfway of the cricoid. Then there's a type 2 cleft, and type 2 whole cricoid there's a split in the whole cricoid. The type 3A, again they have type 3, and this is up to clavicle. That means this is extrathoracic. Type 3B and type 4A is up to carina. This means intrathoracic, and type 4B it's to the bronchial. So this is our own cases. Let's see. Every time this gets stuck. So this is how rigid computer can appreciate it is almost type 1 cleft. And if you see, this is the child with a BBB syndrome. So most of things, that's why again it's very important when you perform rigid endoscopy also. Two things. If it's a tracheostomy child, remove the tracheostomy tube and try to see the movement of the glottic region in a spontaneous way, how they behave by closing the tracheostoma. And if it's already tracheostomy, always for a cleft, we should palpate it. This is the redundant mucosa. We can appreciate in a type 2 cleft, and there's a SAL, that is synchronized airway pathology due to the long-standing tracheostomy, suprastomal granuloma. And this is the last case, almost about 10 days back. I'm lucky to get this kind of video. And there's a type B cleft. And when I first saw during my endoscopic evaluation, I think we are lucky, but not for the patients. I should not say in that way. But you can appreciate how much extension the cleft he has. So it's a type B cleft. The God has given. I have, when I go through the book of Monier sir, the why this how this redundant mucosa help in case of a type B cleft. Though this gave a respiratory distress, but that how they prevent the aspiration also. So basically in the management part, both we have endoscopic versus open procedure, and for type 1, type 2, type 3, we can go with endoscopic way, and type B and type 4, we can better to go with a open surgical approach. Sorry. one we should observe most of the time. Sometimes it's due to they require the CPAP or BiPAP. But more important in the feeding position. If he has issues with the feeding, then we should go with the thick food, and PPI is because most of the children has associated gastroesophageal reflux disease. If he has a severe feeding issue, then we should go for feeding tube. And if he has a persistent symptoms, we'll go for endoscopic care, but we have no experience of type 1 cleft for endoscopy repair. Type 2, we initially, though we have not that much of experience, but we basically go with the rice tube feeding. But endoscopic repair who have not tolerate food at all, have a severe aspiration, then definitely we should go for endoscopic surgical repair. So I'll share one video of type 2 cleft repair, and stop sharing. I think my video is visual, and this is a 45 days old baby with NICU, could not remove from high flow nasal cannula and episodic respiratory distress. And this is his endoscopic findings. Then we have seen here very redundant mucosa. So if you find any kind of this kind of mucosa, and then we should always best way to do palpation in the posterior glottic area, and that's where this is very important to know the extension of the cleft. And also we should assess the full airway. This is how the vocal cord detector, we can split the posterior part of the glottic. Now we did track because we're not that level of experience to go this kind of cases with any spontaneous, but I have seen most of the centers, they go with a spontaneous in and out ventilation. And this is the redundant mucosa. We have cut with simple seizures, laryngeal seizures, but I want to share that this should not be much, so that we have to lose too many of tissue for stitching, and that's how we can, the whole tissue is making the edges raw. And most important, up to apex, we have to make it raw, and then start the suturing with a 60. No, it was a 50 vicryl, but you should have required a longer thread so that we can get the knots in outside the laryngoscope. And it is very difficult. And basically, we required a very good Storz needle holder. Neither the 6U needle, it's every time, truthfully speaking, it will require almost 4 hours to prepare the whole cleft. Dr. Dr. Khansar was also there in our team. And this is how we're putting the sutures. And we have to see that the sutures does not took the adenoid also. It's very tedious, very challenging. And but ultimately we have succeed to repair the whole cleft. And we try to be suture in the esophageal end or pharyngeal end. And it required a very good knot pusher. And we have given almost 5 or 6 knots to complete the cleft. This is the ultimate repair of the cleft. We have extubated the child on the next day after decannulated the child next day, and 6 week post of laryngoscopy. This is the glottic. So this was type 2 cleft. Just I'll want to say last one is just a minute. This was operated 5 days before in the COVID period. The baby is now still now in NICU. We have decannulated the child, and we have take help of all the guidance because I was confused. Should I go for endoscopically or should I go for open approach? And we did first track, and this is all the magnified image, and it was a 15 days old baby, and the baby was initially diagnosed as a tracheoesophageal fistula, and we did track, and but I don't know. I'm trying to get the good tracheoesophageal petracheal flap, fossa, but I don't know. There's lots of fibrosis, so I'm not getting proper plan of petracheal regions. But then I was concerned regarding the nerve, because if I go for the tracheoesophageal groove in blindly without getting the plan of the petracheal fossa, then I want to, because I have a whole surgery I have performed in microscopic. Then luckily we get the left side. This is a head end. This is my left side is a head end, and then this is how we get the left side recurrent. So, and this is how the recurrent, you can see the appreciate the recurrent in the left side. This is up top is the left side. Left side is a head end of the patients for your orientation, and this is a whole trachea. And again, because this is a one landmark where in other way, recurrent laryngeal nerves gives the groove, the tracheoesophageal groove, to where I can go to separate in a 15 days old child in a tracheoesophageal trachea and esophageal plane. And luckily, both this side I can delineate, and also that both the nerves in my field, that way they can preserve the nerve also rather than doing injury. But generally, in case of reconstruction, generally don't search for the nerve. But since I'm not getting the proper pretracheal plan, so that's why I'm try to delineate the nerve and try to get the proper tracheoesophageal posterior wall plan next. And the stress user, and you can appreciate the apex of the cleft. So here our pediatric surgeon Manusa sir was also there in that day OT along with the count sir, and you can appreciate here the apex of the cleft. That's the cleft. So we are trying with a tracheostomy tube Okay, but it's obscured the whole our surgical field. Then because it was almost slow, then we tried this 2.5 size endotracheal tube, but again it goes and just if you introduce little more, then it touches the carina because it's too low, and it was the cleft was almost 3 feet, and the baby start dissociating. Then I have put the scope. Then we have found that the endotracheal tube doing injury to the left bronchus, the tip of the. So we should be very cautious during the on and off of the endotracheal tube, so that the service does not uh, and this is the challenges in operating procedure. After that, we try to cleanse the trachea from the esophageal wall. And thanks to Jaikoma Menonsa, who will give the all the diagrammatic teaching on the day before the surgery. And that's how we can get the plan because the Riles tube is on already in the lower esophagus, and this is a trachea, and we can get the we can sclerotinize the whole trachea and esophagus. Can you appreciate this is the fistular stack we can see through the tracheostomy one. And most challenging is getting the upper part of the cleft. And but at last we can succeed to mobilize the whole posterior wall and esophageal wall. Then Monusas, I start repairing. He is a pediatric surgeon, was present there. So he's my senior, he's my guru, one of my guru. So he started repairing the esophageal wall, and we rotate the trachea and we start repairing the tracheal wall. But issue is that if you see here, if that's my answer had told me that you will get enough mucosal thing, but be kind that you should tracheal side should get more mucosal, so neither it will be becomes stenos. That's and now we start the repairing the posterior tracheal wall. This tube in situ. So we just rotate. If it is very good sclerotization of the posterior tracheal wall, sometimes it may require graft, and I'm discussed with Manansa also. Should I go for the upper part? Should I go for a cartilage placement because it is if you go a position of the only the mucosa, then definitely there will be narrowing, and but it's very difficult to stabilize. According to very difficult to stabilize the cartilage. Rather, you can go with a graft. If you see temporalis fossa or something, if you see there's a too much of shortening or narrowing of the tracheal lumen, but we have repaired the wall. And that's full repair of the posterior wall of the trachea. Then this is an endoscopic view. And baby was, and we have did also the feeding jejunostomy, and baby was shifted to NICU. So in that's all, just last bit of few 2 slides of my. So there may be one dehiscence, there may be subglottic stenosis due to the deficient posterior tracheal wall. There may be chances of tracheal malacia, also the recurrent laryngeal injury. And if you have a not good position and tight position, there's a very chances of recurrence of the fistula. And that's all my talk. Thank you, sir.
Brilliant, absolutely brilliant. Really thoroughly enjoyed. It's actually my dream to do a type 3 repair, and the best person to really tell how it is done is Dr. Raman. He should tell the endoscopic repair of the laryngeal cleft.
Dr.
I must confess that type 3 clefts we haven't seen, and it's very rare, and that's why it's so important to have a center in a place like Guwahati where they've got so much of clinical material and their skills are really coming up. So like we have a series of about 10 cases, I'll just roughly tell you. And out of that, most of them have been type 2 or type 2A clefts, mostly type 2A and one probably type B. I must also tell you, okay, that's very kind of Deepa to put this out. You can see that the age distribution, then the children who have been tracheostomized, by and large, we try not to tracheostomize them. And the total patients was 10, and out of that, one of the earliest cases we did, we were very ambitious. I think Shashi was also there during the first workshop where we attempted to do robotic assisted, and I must confess that it was a disaster.
I was also there, sir.
Oh, you were there. Okay.
I was also there.
Yeah, but I don't. Yeah, it was a disaster because the arms of the
Exactly,
robo
sir.
is not that good enough for pediatric work. Even as on this day, although they have people and the person who attempted the surgery had robotic experience, but the problem is when you're operating in a new environment, new place, and things like that. So I think at the moment we need to still hold on to the robot till we get the right kind of robots. Then the other next case we had was endoscopic with CO2 laser. So now it is standard, we're using the CO2 laser for these cases, and most of the time we do microscopic and endoscopic. This is called the COMET procedure. That is the combined endoscopic and microscopic procedure, because the endoscope has got tremendous amount of advantages, but then the problem is that it comes and occupies a space and somebody else is using the endoscope. So that is the issue. And laser by and large we've been using. And most of them are endoscope, microscope, endoscope, microscope kind of a thing. But then we started doing, I saw a wonderful video from the Great Ormond Street where they mostly do everything under cold steel. I said we must regress and see whether we can use cold steel. So we tried cold steel also. Let me make it very clear. Ours has also been a learning experience and it's taken a long time. Biswajit, you're not the only one who takes such a long time. I also take a very long time. Putting the sutures is not easy. Double layer sutures, we've attempted in some, depending on the size of the baby. Many of these babies are syndromic and they are very small for birth weight. So this is what our this thing has been. I mean, our series actually, and of course I told you about this case which we lost because the child was waiting for the workshop because it was a difficult case, and unfortunately that couldn't be done. Now coming back to basically the diagnosis part, Biswajit gave some very good videos, but the main thing is to separate the arytenoids and see and go to the peak. The incision has to be done at the peak, and here's the child. Can you just play that? Oh yeah, can you just play the video, Deepa? So this is just a repetition, but then sometimes your basic things. You see, when you just look at like this, you won't be able to make out whether there's a cleft or not. So it's very important to use the L-shaped instrument, which you use. See, right now everything seems to be all right. And then when you take the instrumentation and then separate the arytenoids, go right to the apex. Sorry, this is unedited. And the first stitch, you give the closest to the apex, that will be the ideal. So you take this instrument and then separate and have a look there. Unfortunately, sometimes the surgery goes well, the videos don't come out well. That's what happens to us because of various reasons. But here you can see the apex, which showed, Biswajit showed it very beautifully. I'm actually, he did a beautiful job there. This is a 2A type, 2B type cleft. Which we managed to, this was the case, I think we did it in cold steel, we did it. Otherwise, we have one or two pictures of the ones we did with the CO2 laser. The idea is to get this thing, I mean, what's it called, raw area to raw area. And I don't know how much of a problem Vishwajit had. Sometimes even the vocal fold separator or retractor tends to come in the way. And then we of course use a rubber band, which was mentioned in the previous, and then tie it up to the to the laryngoscope. Nothing much. Basically, diagnosis is a thing, and if you get the case, and then if you are trained in surgery, I think you can do that. I don't have any experience in the open surgery for those clefts. For the type 3 and all that. Many of them don't even survive and come to the right hospital in our kind of setting. That is the story. Then after that, of course, very important to evaluate the child subsequently, the swallowing part, and you must do the fees and then check out, and that's the ultimate proof of the pudding. And we try not to put a tube there because it could weaken the sutures, so you do a peg feed for some time in some of these cases so that you don't have something rubbing on the suture line. That's very important. Yeah, with that, I think I would.
If there's any comment from other experts on the panel.
But let me congratulate Vishwajit again for fantastic
Absolutely
work.
brilliant.
Thank you, sir.
Really
Thank
good.
you, sir.
From
Samitra, you are mute. Samitra, you are mute. Please unmute.
I had a similar situation, not a congenital fistula, but it was a gunshot injury causing a hole in the cricoid. And it pretty much looked like this, adult patient, and that required a laryngotracheal anterior and posterior grafting, and he did well. So one of the places, like in a type 3 cleft, I would be the one in which Jeet was showing the gap and the cricoid deficit.
Exactly.
Just because, you know, the vocal cords are anchored to the cricoid, and for the movement of the larynx, you need the integrity of the cricoid. The posterior plate of the cricoid needs to be intact. If it's a horseshoe shaped and without the posterior plate, the adduction and other muscles are not functioning properly. So putting a graft for the function is definitely a good idea there. That's one thing, but
To
you know,
stabilize the issue.
to stabilize the cricoid plate and as a child grows, because what may ultimately happen is this tissue may contract, and we may end up having a stenosis there. But even then, we can do a later grafting, because you know the main idea is to make the child feed normally. And I have to quote you that Mike Rutter, in his when we were like observers with him, used to say this famous quote: "In your life, you'll find once in a while where you put the tube but you're not able to ventilate. Then always think of the fistulas." So it always, you know, rings in the back of my mind. If you have put the tube in a neonat or other things, and you're pretty sure it's in trachea and the child is not ventilating, the fistulas are the first thing to think. That's just the word.
And I think in some one small comment, tibial periosteum has been used to augment that area.
Arpit, there is a hidden.
Arpit, please, yeah.
Very nice point by Shashi. Then whenever you're not able to ventilate, you should always think of, like, you initially start to ventilate, but suddenly you see the abdomen bloating. That is the point where you should think whether it is the T fistula.
T fistula, yeah.
Other thing is the common presentation may be this occasional cyanotic attempts. Cyanotic presentations. So this prolapsing mucosa may just totally occlude the tracheal lumen, and patient may be present. And it's really a commendable surgery by Vishwajit. Open surgery is too difficult, and managing all these small structures. Awesome.
Thanks to my anesthesiologist and the pediatric team, Arpit, it is not only me, without them, because how many times we have in and out that tube, if you count, then and that's credit goes to my pediatric. And also my teacher Joy Kumar Menon sir. I can share our first child. He is, if you ask Joy Kumar Menon sir, he was a Zuganta Gogoi. Sir knows the name also. He had open and now there's a child now is a midline defect. He has all these defects. BSD, bifid scotum, all midline defect, and he had referred the child, and now the child is totally okay.
So
Wow.
we happened to do a type 3 endoscopic along with Dr. Kishore Sandhu.
Yeah.
It was just like again took 3-4 hours, and but somehow the instruments work. The laser we use initially,
Exactly.
the microscopic beam laser, but it was not working. Then we had a luminous fiber laser. So we took incision with the fiber, and it came out so well that 2 layers. If you can just give me 2 minutes, we can show that video also. It's a
Sure,
beautiful
sure.
to watch
Yes,
actually.
please, please.
One quick point. Once you do the suture, you may have to do an arepiglottoplasty for these children.
Yeah, yeah.
So
That's
to
that's
prevent.
important.
That's
That's a good
standard
point.
these days. And
So what your mind doesn't know, your eyes cannot see. That's the main thing, huh? In a cleft. They are so rare.
I don't think so. The number of cases that Vishwajit has got.
No, sir. No, sir. We are lucky. Our
So can you guys see my screen?
Yes,
yeah,
yes,
yeah.
we can.
Yeah, so it's a 1.5-year-old female child with recurrent URTI and intermittent stridor. Had a history of cyanotic episode. Eventually went to emerge, pediatric emerge, where she was resuscitated and intubated. That time there was no diagnosis of this T fistula. So patient was managed with the intubation in the ICU for quite a while, and they somewhere patient before that was seen by ENT, and they scoped the child and they thought there is a kind of a laryngeal swelling. So they biopsied the child for this swelling. And what they found was there's a bulging laryngeal mucosa, but it was actually a cleft from where they took the biopsy. It turned out to be laryngeal mucosa only. So it was all bunched up mucosa that you were seeing in the trachea. So this is how we actually diagnose it, like by doing a rigid scopy with the Lindholm vocal cord retractor. It was a type 3 going beyond the cricoid. So we started with the microscopic incision of this free edges of the mucosa, microscopic laser beam, but eventually somehow it was finding it difficult. So we switched over to the fiber luminous CO2 only. And you can see the way it was creating 2 layers. The tracheal layer and the esophageal layer was 2 real clean layers basically. And again, the idea is not to kind of remove the mucosa, try to preserve as much as possible, because we are going to be suturing in 2 layers so that there shouldn't be a too tight a closure. Sorry, next. Again, the suturing was very, very, very difficult, and it almost took 2 hours to suture this in 2 layers. Somehow was able to do that. And again, Dr. Sandhu was carrying this half circle needle from Switzerland. So that was a real useful, along with the scope we used was a modified Parson. So the long bladed scope, which was able to go beyond the vocal cords, we were able to suspend in such a way. And we put a tissue glue after that. This is the post-op scopy after 3 weeks. Just the technical point, the Parson scope and the modified Parson. So this long bladed scope is really helpful in getting exposure of the posterior part in the instrumentation. And apart from that, if you've got a half circle needle, that is really very makes your job little easier than the other. Yeah, thank you.
Thank you, Arpit. I think it's becoming so interesting. One would love
Yeah.
to go on discussing about
Go
this.
on, yeah.
And moreover, the video was very good.
So
And can't take home.
one,
Yeah, please, please.
sorry. Please go ahead.
No, no, Shashi, good.
So this problem comes. How do we suture it? Is all from the training, and we have to practice it multiple times, because when we were trying to do a slight tracheoplasty, I used to bring the goat trachea every day to my house and suturing it. So the best model for actually practicing suturing, which I used to do it, was take a long 8-inch pipe, suspend it, and put grapes and peels of oranges, and try to suture them, as in cut the grape and suture a grape to the peel. So that kind of gives you the dexterity, and the time reduces considerably. So So that's one thing, as in it's not a very high investment or other thing, but the very patience which is required in moving the arms and other things. If you just use grapes and orange peels, you can just
Yes.
try knots and other things.
A very important point mentioned by Kishore was that you have to feed the mucosa into the needle rather than
Yes.
doing the needle into the mucosa. You stabilize the
That's the
needle
same
and
thing
feed
I
the
learned from
mucosa
him
there.
also. Yeah, that's the same thing I learned from him also. Don't move the hand which is holding the needle. Just pass the mucosa with the forceps on the needle and then you rotate your needle. That makes life easier rather than pushing the needle through the mucosa the normal way that we do in other sutures.
As has been mentioned by, Sashi, Arpit, everybody, and Raman sir also, our plan was also that if we have less mobilization, then we could go for some fascia and tissue glue, but we didn't have to do that eventually. I think we'll pass on to the next speaker,
Yes, please.
and we'll have anyway questions and discussions in the end. So, Sanchita, could you?
Yes, sir. Our next speaker is Dr. Keshavananda Kaur, and he'll be presenting on laryngotracheal stenosis in children. Over to you, Keshav, sir.
Good evening, everyone. Okay, you can see my slides,
Yes, yes.
sir. So today I'll be speaking about laryngotracheal stenosis in children particularly. So as you see, laryngotracheal stenosis, the term itself says it's a complex thing between two larynx and the trachea. So it is. It seems kind of an umbrella term for a lot of disorders, which have already been discussed in previous sessions also and today also. So together it forms a wide variety of disorders associated with this. So with this talk, I will limit myself particularly to with the to how to approach a child with laryngotracheal stenosis, and after the proper diagnosis and staging and all, what should be our primary goal uh, for that particular child, how to proceed for the exact treatment, because the treatment modality itself is quite a wider range of treatment modalities we have for these kind of disorders. So in that ways, I will not be investing much more time on the treatment part, but particularly about how to reach to a diagnosis about what to do for the child. So the etiology, congenital and acquired, there are two varieties. In congenital laryngomalacia, vocal fold paralysis, subglottic stenosis, laryngeal webs, subglottic hemangiomas, these were few of them already been discussed earlier. I'll be focusing more on the acquired varieties, which we acquired ones are the most commonly presented situations we face in our regular practice. The 90% of post-intubation are post-intubation injuries, and few of them are post like iatrogenic complications from endoscopic laryngeal interventions for other disorders associated, like in cases of various laryngeal webs and subglottic hemangiomas, benign tumors. Of course, there is a caustic or thermal injuries, any external laryngeal trauma. Chronic inflammatory disorders seem to be presenting in mostly in cases of older child or in the adult patients. So in post-intubation injuries, what are the factors, which are the predisposing factors which causes this laryngotracheal stenosis? That is the age. Patient factors are the age, laryngeal size and shape, systemic disorders, and gastroesophageal reflux disorder. The endotracheal tube, is it oversized, or if it's a very smaller size with a quite inflated balloon, excessive hardness, the quality of the material, the texture of the tube, a poor biocompatibility material, that may also cause irritation. In cases of intubation, if there is a history of traumatic intubation or there is a history of repeated intubations, a crash intubation followed by a tracheotomy, which may also lead to stenosis or prolonged intubations. And in nursing care, like poor patient nurse, poor patient sedation, the child is quite more mobile during his excessive mobility while on intubation. Excessive ET tube motion is there. If there is associated nasogastric tube, if it is in place, which can cause compression of the tracheoesophageal membrane, and the traumatic ET suctions may also lead to injury to the tracheal mucosa. So how the pathophysiology is, how it occurs? Mostly in the intubation, if the during the intubation times, if the the laryngoscope is not pulled instead of, but it is rotated, like in the adults one. So then in that case, there is a very difficult. The larynx may go more high up than it should have been. So in that case, there is a high chances of injury to the larynx because of failure to see the larynx properly. And in prolonged intubation, there is a two pressure points between the interarytenoid region and in the subglottis. There are these two pressure points which on prolonged intubation can lead to necrosis in these areas. So what exactly happens? It's the cuff pressure. If it increases more than the capillary pressure in the membrane, it leads to mucosal edema and ischemia and ulceration in the area, which in turn exposes the cartilages, and it causes perichondritis, chondritis, which later on heals by secondary intention, causing granulation tissue proliferation, which there is a deposition of fibrous tissue, and later on these fibrous tissue form a firm scar narrowing the lumen. And the duration of intubation is very much important to know. As in cases of adults, it's nowadays it says 5 to 10 days. Or it's the limit. Beyond that, they also may develop stenosis. But in cases of children, we cannot say there is a difference. Some literatures do say that up to 14 days, but it's very much, if there is a need for a ventilation or some issues which may need more than a week's time, that's better to have a child to have a tracheostomized. Premature infants, they need also longer period of intubations. Usually they tend to develop. If there is a ET size tube, the tube size is the cuff pressure should be adjusted in such a way that there should be a leak in the inspiratory pressure along the tube, which is approximately 20 centimeter of waters. So in cases of infants weighing less than 25, a small size of tube of 2.5 mm is used, then there are the chances of there are very low incidences of laryngotracheal stenosis. So these childs usually present with stridor, restlessness, irritability. There may be dyspnea, tachypnea, apnea, cyanotic spells. There may be weak or hoarse cry. There may be aphonia. There will be aspiration with recurrent pneumonia. In mild to moderate cases, the children are asymptomatic. There may be very minimal features which go unnoticed in till 1 to 3 months of age. In majority of cases, the child may present with croup, atypical croup. It may be like the multiple episodes in the first year, which needs a multiple hospital admissions, failure to respond to the appropriate medical management, needing endotracheal intubation. So these cases have to be addressed and looked after in a different way, not in the traditional way. So as you see, there have been a lot of classifications going on laryngotracheal stenosis because of the areas involved. There have been developed a lot of classifications. We'll just briefly go through a few of them. Like the Mayer-Cotton was established in 1984, then McCaffrey, Leno, Netterville, Cohen, Bogdasarian, and Lacura et al. They all have given different classifications. So Mayer-Cotton, which is widely followed, it's basically on the subglottis and tracheal. We all know that it is followed in subglottic region and particularly for the tracheal region. So it's from all the gradings, grade 1. So it's already been discussed, so I will not go through them. McCaffrey is another one which is basically divided based on the subsites involved and the length of the stenosis. In the stage 1, it's in the subglottis or trachea, which is but less than 1 centimeter long. In stage 2, it's in the isolated subglottis with more than 1 centimeter, and stage 3 is subglottis or tracheal, not involving the glottis, and stage 4 is where the glottis is also involved along with the subglottis. Lennon-Netterville classification, it is based particularly on the subsites. It's divided into 3 stages, 1, 2, and 3. And 1, 2, and 3 means that all the subsites, if one subsites, any of one subsites is glottis, either glottis, subglottis, or trachea, or any 2 glottis, subglottis, glottis, subglottis, and trachea. That is stage 2. In stage 3, all the subsites are involved. Cohen particularly classified the anterior, as Dr. Khaund has already described in the laryngeal web. So basically, it's for the glottic stenosis, and particularly the anterior glottic stenosis. Bogdassarin et al. Also classified it. They classified particularly for the post-glottic stenosis, where they divided into 4 types. Type 1 is a vocal process adhesion. Type 2 is the posterior commissural stenosis with interetinoid scarring. Type 3 with posterior commissural stenosis with unilateral cricoretinoid joint involvement and ankylosis. And type 4 is bilateral cricoretinoid joint ankylosis. Lecorai et al. Also described classification on their classification was based on laryngeal fixation and the subsites and the laryngeal joint involvements. So presently, what we are following, or it's the newer classification which have European Laryngeal Society has, Laryngological Society has classified with Monier et al. As the ELS classification, which is based on basically clinical findings of the multiple tests. For this, the endoscopic workup has to be done accordingly. In there are 5 key point procedures which are done. There is awake indirect laryngoscopy or TNFL, and a sleep TNFL, direct transoral laryngoscopy or with a 0-degree laryngoscope, suspension microlaryngoscopy, and bronchoesophageoscopy. And based on all these 3 findings, all the 4 findings, it is classified. So in the radiological part, as previously also discussed, presently it's the HRCT of the neck, along with the remodeling of the airway, virtual bronchoscopy. There are all ways we can do, but the clinical examination is gives us a far better opinion about than the radiological aspect. But that doesn't mean that we should not be going for these, but these are also an aid towards our diagnosis. We also need to have, according to the ELS system, has to be a functional assessment. So functional assessment we have to document if there is any stridor at rest or during exercise and physical activity. Pulmonary functions tests have to be done. Voice evaluation has to be done. Of course, in very small unit, we cannot have a voice, but in elder child, we can have a voice evaluation. And the assessments of the patient's general conditions. If there are comorbidities associated, usually apart from post-intubational, if the primary cause of intubation was not some congenital laryngeal problem, but rather than some neurological problem or other pulmonary or cardiac problems, because of which the patient was intubated, that has to be completely addressed and assessed. So based on all these findings, the final scoring is done, which is basically a combination of Meyer-Carton scoring, which according to grading of from 1 to 4, and a revised version of Lennon-Netterville, which was based on the subsite. Here, the supraglottis in the revised version, supraglottis has been added as a 4th subsite. So according to that, from A to D, they divide have 4 subsites, and the associated comorbidity and any congenital abnormalities, if present, they give a plus sign is added to the final scoring. So this is the ELS checklist by Monier et al. Here we can see that all parameters before deciding for the for before reaching to the particular diagnosis and deciding to go for what procedure exactly the child needs. These meticulous charting has to be done. So this is how the final charting is done in according to the staging. The Meyer carton here, then the isolated groups. They according to the subsites, it is divided into A, B, and C. This one. So decision making. So decision making in cases of laryngotracheal stenosis, there should be a board of team to decide the type and to do for the timing of the surgeries. Particularly, ENT surgeons, neonatologists, and intensivists play a majority, take the majority share of the decision. But in the panel, we must have because the goal of any laryngotracheal surgical procedure is to achieve decannulation and to reestablish an airway while preserving adequate laryngeal function for airway protection, swallowing, and voicing. So this is the final way of just a flow chart of how the grading is done and then how we go for the procedures. Like in grade 1 or 2, we can have a very mild cases when we can wait and watch for the symptoms onset. If there is any symptoms, then we can go for endoscopic treatment. If there is a failure, open neck procedures. And similarly for grade 3, 4, we can decide along with since we can go for directly for open neck procedure, but what and which procedure has to be done, it completely is decided upon the previous staging systems. I'll just briefly, you can see my video. Hello.
No.
Sir, not yet.
Just a second, then I will just. Okay. So now my video is visible.
Yeah.
So this is a case with laryngotracheal stenosis that it came. This is an 8-year-old boy with tracheostomy for last 5 years. On rigid endoscopy, we found here you can see that there is a slight anterior glottic web here, and the cords, the vocal folds here, they are completely in the midline position. We cannot see there is complete adhesion here. So once we are, but we should not just stop here, because you see once we are through the glottis, you can see that there is another complete stenosis here almost. It's more than 90% stenosis over here, very barely a small hole over here. Patient is also in tracheostomy. So here you can see that there is hardly any movement here in the interarytenoid region. And this is a reverse telescopy done through the tracheostomy. So here you can see it is the stenosis from below. So in this picture particularly, so see that's how the endoscopies and all help regarding to reach to a diagnosis and what to do. But initially it looked like just a simple glottic stenosis, but if you're not went through the glottis to see below, then we might have end up terribly in taking a wrong decision for the treatment. So role of tracheostomy here. In cases of mild stenosis, earlier said that in grade 1 or 2, we can have observation. And in cases of, if the patient is deteriorating, have respiratory effort, then we may in cases of grade 1 or 2, we may go for straight away for the reconstructive surgery to avoid a tracheostomy, because tracheostomy in those patients may don't turn up well, because tracheostomy is as much as far as possible has to be avoided if possible. If unavoidable, then we obviously we have to do a tracheostomy, but tracheostomy has to be particularly selected in which areas we have to do. We'll have a separate discussion on tracheostomy tomorrow, so I'll not go much on this. So the management part, it is tailor-made for every patient depending upon the staging done after the grading system. So we have either we can go for an endoscopic approach, a stenting, there are a lot of stents available. Then we can have open surgical approaches, and we can have a combination of all the procedures either in a single stage or in multiple stages depending upon. So in endoscopic procedures, I already discussed, like lasers come quite handy, ablation, laryngeal wound especially. In case if we need dilatation, several killer dilatation are available. The balloon dilators, Fogarty are also very much, they are very much useful in cases of very small membranous subglottic stenosis kind of things, or in the glottis also you can use a Fogarty balloon. They are very excellent and very soft, pliable, and they are quite appropriate. We have used quite a lot with Fogarty because they are quite easily available if you have a cardiothoracic center with you. So the stents, we have a variety of stents with Montgomery T-tube. The Healy pediatric tube is available with which comes with an inner cannula. The Montgomery LT stents. So these, there are a variety of stents which can be used with the along with the adjunct to the endoscopic procedure, or with the open endoscopic open surgical procedures. So surgical procedures are like laryngotracheoplasty, laryngotracheal reconstruction with cartilage or without cartilage expansion. And then there may be have a single stage laryngotracheal reconstruction. So these all have to be decided. Once we have reached to a conclusion that we have charted everything in the place, and we have everything in place, then these procedures come into play. Which one is better for the patient? So this is one slide I would like to show there, how if there is a isolated tracheal stenosis or any laryngotracheal stenosis, we can actually measure the length with the scope. As we discussed in the first day also, this is how we measure it. Once it is in the glottis, we put a mark here, then the upper limit, the lower limit, and the carina. And based on this, basically this is required for in cases of where we need to do how much of resection is needed if required, or if we need to put a stent, what should be the exact size and the length of the stent. This helps in that ways. On conclusion, I would say that airway management is always a teamwork. It's not a single entity. It's always a teamwork. The right time and right procedure for the correct patient has to be selected. It's always rely on previous experiences. Know when to change if things are not going the way it should have been. Decision making should be meticulous. We should have sufficiently the resources has to be available with us. If we are not that much resourceful, so we should not choose on to decision of without having proper resources. We should always have a backup plan. Thank you.
Thank you, Rishabh. Thank you very much. Dr. Shashidhar, can you come in?
Yeah, about the classification, he opened my eyes with several new classifications, which even I didn't know. I was in Switzerland this year beginning, and in the conference we had this airway course only at Dr. Sandhu's place, but nobody actually bothers about the classification for a simple reason. Your actual intervention is completely tailor-made as per the patient. You may have a previously endoscopic, and even if it's a grade 2 stenosis, you may opt to do an open endoscopy, open surgical procedure. But that form which Dr. Monier has put in the ELSS, that's the most important
That is
form,
the important.
which kind of tells you where exactly you have to look. You have to look for eosinophilic, like esophagitis, core syndromes, everything, because everything lies on your assessment. You are not going to operate a reactive larynx, rule number one, and you are not going to operate a single stage procedure on person with a lot of comorbidities. These are the dictums. So, and when we had the discussion about neonatal tracheostomies and everything, uh, that's the place where the stenosis happens. So the old adage was put the largest tube possible to ventilate a child. It has changed to put the smallest tube possible, which has the air leak to ventilate a child or other things. And surprisingly, preterms and as the child ages, the tolerance to the endotracheal tube decreases. So preterms can tolerate the endotracheal tube up to 1 month, 1.5 months, 2 months, 3 months, they can go. And in our own NICU, we have seen as early as 24 weekers have, passed on very well with the tube for such a long time. Less than 1 year, you have some really good capacity to take intubation for prolonged period of time. As you grow towards 5 to 10 years and elderly, then the problem of stenosis is there. So, but I would definitely want to put it in, to assess in the comorbidity. But if I have to decide my surgery based on a classification, definitely not. The bottom line is classification tells you how severe the problem is, but you'll have to do with your own guts what is the surgery which you want to do it. And apart from that, I think you researched it extremely well, uh, getting all the different classifications and everything, and this is much more useful to say how we have evolved into it.
Yeah.
And thank you for putting ELSS. Now I'll go back and read today.
So this is the new which I was going through. So because I also never used to follow all these classifications. The thing is ki, you don't get the things the way the classifications are, because it's
Yeah.
always a combination of things.
You
So
don't.
you have to tailor made everything according to that.
You don't, and you don't. And about the tracheostomy, we have anyway discussed. We were discussing in a different forum. Sorry. So, do you want me to go through the slides because it's getting
Yeah,
9 o'clock, Dr.
yeah,
Gautam?
please.
Okay. So,
Please.
so I'm just putting what we learned from India. I don't want to put what's there in the literature. And this presentation is very close to my heart for a simple reason. Uh, it just tells if you're in India and learning LT surgery, what all things go into your mind and what is going to happen. Just a second. So basically, this video which I made says if you have to learn ENT, laryngotracheal surgery, the first obstacle is actually the rep graft. Most of the people will not do it because of the ref graft and do all the other procedures. So there's a complete contrast how developing countries and underdeveloped countries are doing the laryngotracheal surgeries. And it starts with the basic premise that when you go outside and learn it, you say that the cases in developing countries are many more. And when you are looking from the developing countries perspective, you say, they do LTR, PCTRs, and slight tracheoplasties, stem cells. I know, and he is better, but they also think they have more cases. So the problem is still not solved. What is the best scenario to be in? if you were to be in a developing countries and you have learned the art of PCTRs, LTRs, and everything, you have got the best of the both worlds, and that's the typical place where you have put India. So from the junior perspective, it's actually the tools are not very important. uh, there's no big deal if you don't have a laser or a coblation or other things for laryngotracheal surgery. They're not the bigger tubes, and T tubes have to be, for some reason discouraged, and that's the central thing. Because when you go to the evaluation of surgeries, we started in 80s with a 67% success, then we went to 92 little later by uh, mid 90s, and now we are approaching 1995. And when you look at the publications, USA and United Kingdom and Europe, they are the top leaders. This is like a pure laryngotracheal revision case series which I'm picked up. So these are the number of publications. They have not case reports but case series, and India is hardly two. Arpit would have published one, and the other one, Bharti ma'am, would have done it. So there's very limited publications from Indian side. Now, when you see, what causes a failure from English articles, it will come. If you look at here, T-tube requirement was highly predictable of decannulation failure. They say if you have to put a T-tube in the laryngotracheal surgery, it has the highest prediction of failures. And of all the things, GRD, little bit, diabetes, definitely p-value was significant, and several factors are here. But if you do a secondary tracheostomy, that's a bad sign. As in, during your treatment, the patient had to come up with a tracheostomy. Grade of stenosis, which used to be a big deal, is not a big deal anymore. But when you look at the Indian publications, everything changes. And this I'm quoting it right from 1960s to everything. Was always T tubes, T tubes, and T tubes, and our success rates are amazing. 87.5, 3% had granulation, no comorbidities listed. This is one article I'm quoting, not to criticize anyone, but I'm just trying to say that how is Indian literature going on. This is another, and that's like 111 patients, 71 T tubes, 92% decannulation rate. Another one, 82% decannulated, and all they did was T tubes. But when you look at the articles, they have not put how many these laryngotracheal stenosis were subglottic stenosis or tracheal stenosis, or what was a vertical extent. None of those were measured or other things. So you have to take those results with a pinch of salt. So this is the Cincinnati form, and this is 20 years back. This is their form. So your ELSS form, which whatever they had, this has almost everything of that, and also the surgery and the post-surgery drugs, everything on them. And this is what we've been following. We also have our little patient assessment form and other things. So I'm skipping the assessment and other things. How do you assess comorbidities? You have to take swabs. You have to look for decision making. Also, I'm skipping it. But basic premise is that when no comorbidities are there, try to do a single stage. When the vocal cords are bad and neurological status, heart disease, aspiration, these are the issues, do a tracheostomy and do a stage procedure. And this is a golden advice, and this doesn't change. Now, this is a laryngotracheal where you're putting anterior and posterior graft. I'll skip these things. Most of this you would have seen. Now, what has changed is two things. Over the years, we almost always used to do simple suturing. Now we do a mattress suturing here. This has changed. Why? Because Cincinnati changed. Don't ask me. But even if you the Munoz diagram, you'll see they do a simple single suturing. But I have not found a real difference in this. But the closure and the tight seal, which used to get is much better when you have a mattress suturing here. Do you have to use a fibrin glue? Answer is in the first few cases which you are starting to do your LTRs, do use it, because some centers like in Europe would swear by fibrin glue that after an LTR you should put a fibrin glue. Uh, in Cincinnati they try to put a fibrin glue in between, but later now it's not a big deal anymore. But given a choice, they would put it. Stents again. Now we are using Rutter stent. Karthik and Doug were very generous to lend few of them to us. But you can use a Portex tube, and this limb comes out of the tracheostomy tube, and this worked pretty well for the first 40 LTRs for us, and we never had any accidental stent outs. But I've seen Monier LT mold getting accidentally gone into the intestine and causing intussusception, and patient ending up with a abdominal surgery, and that too in Oman. I have seen with all the other stents which we have tried to manipulate in this. This was pretty sturdy, but with Rata stent you will never get one of those stent dislodgement. Again, I'll skip the 2-3 management. So about the grafts, this is again an interesting area. If you have a child who's less than 1 year was the original criteria where Euler grafts were to be used, which is take a part here and put it where in the anterior graft. Now, whenever you put a Euler graft, all these procedures they advise you to do a posterior cricoid split. The answer is like a bulldog clamp. So if you're expanding the anterior, there is a strain on the posterior. So the airway wants to come back and collapse all the time. So even if I'm just doing an anterior cricoid graft, I would tend to now give a posterior cricoid split so that this tension is gone, and now this graft is tension free. So this holds it very well. So this has changed. And the age criteria now is actually even up to 2, and some people have used up to 5 years this thyroid Euler graft. It can be even used in adults. There's no literature which says, but in adults you can't do a LTR because of the thickness, because it doesn't give you a wedge. But if you have a segment which is very collapsing or mellitic and you want to do a tracheoplasty and you don't want to take his ribs out, you can liberally take this. For covering the trachea, now the standard graft is actually the pinna graft because of its curvature. Because if you patient was on T tube and you have a large defect here, and he's ready to be decannulated, but just because of the large area, you're not able to decannulate it. The pinna graft, which is named as the cap graft, one of the best grafts to be used in those areas. So this is the first case back 10 years back when we did the thyroid Euler graft, and it holds up extremely well because of the thickness. It does not thick like a rib. It just integrates it into the trachea beautifully. And this is like 3 weeks. You would no granulations, nothing. And with Euler graft, you don't have to stent it for a longer time. 5 days is more than enough. Now, I'm more keen to share the complications than actually the results, because results are boring, always boring. So this is the benchmark case. The patient had 40 different surgeries for laryngeal web, laser, because it had a subglottic extension. Every time the surgeon would go and eat up a little larynx and larynx and larynx. And after 40, there was no recognizable larynx. If you see it, there's no recognizable larynx. So it took us 10 more surgeries to restore it, and we have used 2 rib grafts at 2 different times, pinna tissue. We have used temporalis fascia to reconstruct the vocal cords. You name it, we have done it. This was done by me and Dr. Rakesh. He helped with the last laser surgery, but for the 9 surgeries, I was the one who was doing it. And then we had to do balloon because whatever you're trying to repair tends to come back. Now this guy has taken a Canadian citizenship because the Canadian government has given him a citizenship that he has endured so many surgeries. No vocal cords for the patient. And the airway is like a serpentine airway. And he breathes beautifully. He plays sports and he's an engineer now. And he's got a Canadian citizenship just because he had 51 surgeries to his credit. I'm going to skip this. So slight tracheoplasty is another new thing, and even for tracheal stenosis, we are using it. And it now, instead of doing a tracheal resection anastomosis for a tracheal cervical area, you can do a cervical slight tracheoplasty. The logic is simple: just cut it in the half and slide it above. This increases the lumen, and we are just I'm skipping this. This is a pediatric newborn which is done on ECMO. Just see. So it starts right at the cricoid, narrow, narrow, narrow. Just a 1.9 mm scope going inside. And post surgery, you can see it. So this was interrupted sutures. The second one which we did with a continuous one that did not have the figure of 8. And post surgery was much better. So we kind of improvised on that. I'll skip this. So when we said where else the LTR can be used is the tracheoesophageal fistula. There's a gunshot, then this is a hole in the trachea. So this we had to do a laryngotracheal reconstruction to fill it up. And there's a case. This is crazy case. This is like the whole trachea is weak, and this is called tracheobronchopathia osteochondroplastica. So it just looks like the trachea looks like an esophageal wall. Okay. And then you have several nodules here and there throughout the lumen. So he was tracheosmized. These are the nodules, and these are the lesions which tell you that it is tracheobronchopathia. So these nodules are actually calcium dystrophic deposits. It's a congenital condition. This patient, his brother, and his father, all of them had this condition. So when you do a LTR, it kind of works well. The whole lumen opens up well, graft integrated and decannulated, a very gratifying procedure for him. I'll skip this slide. Now, adjuvants have also changed. There was a time when every case used to be mitomycin, and if I used to do in periphery, I used to call up mitomycin or fibrin glue. You have to arrange for it before we even think of. Mitomycin is out of the vogue, but Dr. Sandhu is still a big fan of it. Mike Rutter hates it, so I'm confused. So, but intralesional steroids are the biggest heroes now. So you see granulations, go back, inject, inject, inject. Mucosal grafts, skin grafts, they're all used. So what we have not used is collagen derivatives. They're actually inexpensive and they can be easily procured. So I'm just waiting. If we get a good vendor, we can use collagen derivatives because they completely integrate in the tissue and you may not even need a cartilaginous graft for them. We discussed fibrin glue. So what are the 4 big complications? And then we cut it out. So this is the biggest problem is you've done a good job, airway open, and you're stuck with the tracheomalacia just above the stoma. And the child won't decannulate. You can strap him, he'll roam around in the house and talk and everything. And he won't decannulate. So it's a very difficult, challenging problem. Redo surgery does help it, but if you just leave the kid and control the reflux and other factors, and possibly balloon it couple of times for remodeling it. So when you balloon it, you're not trying to expand it, but you're giving a directed shearing, scarring in the tracheal lumen, which kind of solidifies it. So using balloon for rigidifying the airway is one of the nitty gritty of balloon, which is very artistic. Even for mellitic, if you, there is some role there. This is your worst nightmare. Primary graft failure happened to me only once. That's because I had to go and do it at a different center, and whatever the reason of infection and other things. So now it's a very, very rare. And if it happens, debride it, redo, and put the graft back again. As in, you have to take a fresh graft and put it. Stent related problems are not that much if you're using a good stent. This is from the silicone NG tube or Foley's tube, which you're using those stents. After an LTR, you rarely get granulations and other things. If you have a Rutter stent or a Montgomery T-tube stent, you are already blessed. But these granulations, the protocol is Ciplox denebulization. So the ear drops, ciprofloxacin, dexamethasone, 0.5 ml of that, the child uses it as a nebulizer after the stent removal. His tracheostomy tube is blocked from the neck and he'll take it inhaling. So both steroid and antibiotic are given. That's Ciprodex drops are not available in India, so that's the closest you can get. This is a severe infection of the stent. Patient turned up after 2 years after putting a tracheal stent in severe stridor. So the follow-ups are important. If they don't turn up, call them up. So we have a diary in which we kind of write it down whom to call when. So patient may delay it and everything, but you have to call them up and say, hey, your stent revision is back. Now this is another problem which you will face is a severe supraglottic edema. Your surgery went by the book, everything was fine, but for some reason suddenly after 3 weeks you see where did that nice lumen which you saw at the time of stent removal disappear? The answer is the reflux. You actually operated on a reactive larynx. If you're too early to operate it, you will find this, and this will haunt you for a very long time. You have to give systemic steroids, anti-reflux, and take multiple culture back from the tissue, not from the uh, discharge, but actually from the tissue core, because the active larynx is the pathogen is supposed to be deeply buried inside the tissue. So the top 5 problems when you start doing it is the cost. Patients will not be able to afford it. You have a knowledge, but it's very difficult to now. Dr. Raman and his conferences are really one of the best places where we can actually go and learn. CO2 laser and other things, even if it's not there's not a big deal, but it kind of affects the outcomes. There is some disability there, but it doesn't stop you from doing the cases. Single stage is very infrequently done because of the PQ limitations, and you may have to go once out to get the whole picture of the training. Thank you, and you always need a team. You can't do it alone.
Thank you, Dr. Shashi. I think you have covered everything so well. Any quick words from Dr. Raman, Dr. Arpid, Dr. Soumitra? Can you come in? Just quick comments because we will pass on to Biswajit's talk also because we are already.
Excellent talk, Dr. Sashi. He rounded up very well the whole session, and we learned a lot from all the things, his experiences. Definitely, it's a teamwork, and all the failures make you learn, and you go back to your teachers, your colleagues, and that was great learning. Thank you, Dr. Sashi, for all your videos and all your words.
Thank you, sir.
Dr. Raman, you wanted to come in? If you have to unmute, you have to unmute yourself. You have to unmute, sir. You have to unmute. You're muted. Dr. Raman, you're muted.
You can
Yeah,
unmute me.
that's it. Yeah. We can hear you, sir.
Hear you.
Yeah, we
You
can
can
hear
hear
you.
me. Okay. Video is not important. Excellent presentation. Both the Dr. Konar's presentation, followed by Shashi, who kind of wrapped it up very well. Regarding classifications, yes, in some ways it's important, but it's not the be-all and end-all as far as the decision-making is concerned. There are about 3-4 important things on the decision-making is what you need to do. One is most important is your skill, and gradually it improves over a period of time. The second one is, of course, the patient's condition. I mean, in terms of staging of the stenosis, etc. But also a lot depends on the comorbidities. And finally, and most importantly, do you have the support system to sustain your success following the surgery? These are the important things. And the other thing about preventing stenosis, of course, Shashi did mention about how children can, you can intubate the children for much longer time depending on the age, and there's no urgent need to go and do a tracheostomy in children. And apart from that, I think this anterior cricoid split and thyroid ala augmentation is a forgotten surgery which can be used much more often, is technically less demanding, and as Sashi was mentioning, it can be done in slightly older children also. So these are the things. And apart from that, I think we must really appreciate the honesty of our surgeons today, to where they've shown their problems, complications. So that's how we learn. So congratulations on being open about the complications, because if you haven't had complications, because that means you haven't done enough. And I'm sure Shashi knows we've been running this program of the workshop for so many years. The best surgeons in the world have come and operated on our place, and we haven't had success all the time. So it should encourage us to be meticulous, learn from them, but not be fearful of any complications. Second, the last point is about single stage and double stage. Unfortunately, in our country, we have to go towards a double stage in many cases where we probably would have done a single stage in advanced countries. That's all I need to say. Wonderful program. Thank you.
Sir, if you wanted to come in a quick word, because Biswajit is raring to grow.
Me?
Yeah.
Yes. Yeah, so excellent eye-opening presentation, Shashi. And I am not a big fan of T-tube. So T-tube, I've seen a lot of referrals happening because of the stenosis developing at a superior and the inferior end. If at all, if you are using T-tube, maybe fix it with sutures at the upper and the lower end, so that it doesn't move with the movement of the trachea. And whenever you are seeing such a granulations in the trachea and all, follow-up scopy, repeated scopy is the trick. Basically remove granulations, infiltrate steroids, and it's really do the good job basically. And Ciprodex, or we use the tobramycin and dexamethasone also, it really works wonder. It's like, it's really kind of changes the whole picture.
Or Pete, can I before going my presentation, can I add regarding the fixation of the T-tube?
Yeah.
Can I add 2 points of fixation? Number one, generally we forget to position the neutral position of the baby. Yeah. Most of the time. That's because it's most of the time in the operative procedure, we have a more extended position and put the tracheostomy tube accordingly. Number one. Number two, if you can have flexible scope from the head end, then you can guide the way actually, so that at how much we have a subglottic level we can put that, because mostly I think the superior granulation is more than us. If it touches every time the glottic and post-cricoid area, interarytenoid area, than the inferior end. That's the two when I can add.
One modification that we have used recently, like along with Dr. Monier only, that we have used the vertical limb of the T-tube only as a silicone tube.
Exactly.
And fix it superiorly and inferiorly with the...
If I would have fixed that's a good idea.
The tibial periosteum. And it really worked very well. And patient has tolerated the tube inside from good as 1 year also. And they didn't have any problem. And it's in a challenging cases and long segment stenosis where you are not able to do an end-to-end, and you have opened up the trachea and everything, this thing can be tried.
How's your tibial graft? I was very keen to understand.
It's very simple, Shashi.
What is the ideal place you want to use your tibial graft?
So long segment stenosis, where you are not able to do a end-to-end resection anastomosis, and there you can like cut open the trachea in the midline and put a silicone tube and then suture the tibial periosteum all around so as to make a complete airtight closure.
So
And
you're wrapping the whole trachea with a tibial
yeah,
periosteum, just not spacing it on the defect, but actually the whole
all
trachea.
around. So wherever the tracheal trachea is there, you will go all around so that that vertical silicone T tube is not exposed to the outside. And when you leave it for a period of good like 6 months to a year, the tibial periosteum kind of solidifies.
Understand?
Arpit, if you have got a video on that, come in on Sunday. Come in on Sunday. Come in on Sunday.
On goat dissection, sir.
Yeah. During the goat dissection, we can actually have some videos of live things for correlation. If somebody has, if you have time, let's see.
It's very easy to harvest also. Like it hardly take 5-10 minutes to harvest the periosteum, and you can just kind of, even in these cases of grafts also, when you are putting a cartilage graft just to augment it. Like people use a tibial periosteum, or sometimes that's the cardiothoracic surgeon use the pericardiums. So either of this, like it is a real sturdy graft, and you can just cover the whole thing.
It works.
Sure, sir. We'd like to see you on Sunday.
Come in.
So can I go before good night my presentation?
Go ahead.
And also the question. Okay. So I almost had to. So this is my last talk of today. Tracheal mass, pediatric tracheal mass, basically. This is a case presentation. The 6-month-old child who presented with intermittent episode of cough with a breathing difficulty, and he was advised. He was diagnosed as a case of an asthma by the pediatrician, and he was advised nebulizer at home for the last 3 months. But there is no as such improvement of his symptoms. So on examination, he has a subcortical retraction, and baby was tachypneic, decreased airant in both the lungs, filled with a polyphonic wheeze. That's the same characteristic of the asthma. That's why he has mimic like asthma, and he was diagnosed as asthma, and he was treated as asthma. So 3 things. So no other significant clinical finding. So when baby was advised for CT thorax, I'll go to CT thorax in soft tray, and we are going for the fiber optic bronchoscopy also, and let's I'll go for the CT scan first. I'll try to share the CT scan of the baby. We have a session on airway radiology. Just on this, particularly for this case, I'm going to see what is the airway. So this is the axial view of the file. If I go from down to up, so okay. Just a minute. So this is the mandible. Then I am going down, down, down. This is a glottic area. This is a vocal cord area. This is a trachea. And going down, down, down. Then we have seen there's a some abutting soft tissue in the left side. This is the right side of the my left is the right side. Then you can see there's a mass in the trachea. So this is a diagnosis of trachea. Radiologically is a fissure. So there's some obstruction in the trachea, and this is the right and left bronchus. So radiology important was importance before going my endoscopy. I want to show here because if you see, if you enlarge the measure his remaining airway, then if you see maximum, this is a maximum obstruction, and you can see there's discharge mass of airway still is present in case of 6-month child. So this is how we can measure, we can intubate the child or not in radiologically, we can get the idea. And how much it's above the carina, because this is the carina. This is the right and left bronchus. This bigger one is the right bronchus, and this is the left bronchus. And how much it's above the carina, we can appreciate that thing also radiologically. So this is this. Then if you go for this, I'll just share the video and that's I'll turn my presentation.
Happen?
Yeah, yes, sir. So this is a 6-month-old baby, and this was a fiber optic bronchoscopy. So that means radiology was done few days before, and it is almost the mass is almost obscuring the 80% of the lumen of the trachea, and we have negotiated 2.8 scope beyond the mass and to see how was the lower airway beyond the mass. So already I have described these things. So this is how the baby was intubated. The issue is was with how if you go for resection, how will you intubate the child? If you intubate the child, how will do the surgery and how will you maintain the airway, particularly lower airway, if you go for resection of the mass. So if what we did, we did the intubation, then through the tracheostomy, we have guided the endotracheal tube beyond the mass so that we can inflate the cuff and we can secure the lower airway. And that's how we have pushed the endotracheal tube beyond the mass. 2.5, this is not 2.5, I think it's a 3 size tube because we have adequate lumen beyond the mass. And we have inflated the cuff to secure the lower airway. Now through the tracheostomy wound, because he was a 6-month child, and from the tracheostomy it was very near actually. The approach was, then we have cauterized the mass with a monopolar cautery, and we can use coblation also. But if you have a MLW1 and the mass was removed in the fish mill, and sees we can intubate the cell beyond the mass, then if you can do anything, and it's if you see the approach from the tracheostoma, if you do a very low tracheostomy and you extend the tracheostomy wound, then its mass is almost in your field. It's like a kind of a open surgery with a look, mind, this is a 6-month-old child, and we are doing all this with a 4 mm scope, and with the help of scissors, still cold instrument only. It's a little bit difficult to negotiate with a 4 mm scope, 1 suction and 1 cutting instrument. but with the time and patience, we can debulk the whole tumor from the tracheal wall without doing any injury to the tracheal wall. And we should not do too much work on cartilage. And that's how the whole mass in toto we can remove. And we put the cuff for 1 day, endothecal tube, putting the cuff over the operative field so that there should not be any kind of bleed overnight. And we have removed the endothecal tube on the next day, and we extubate the sile, and we extubate the sile. We extubate the sile on the next day, and this is the remnant of the mass. We have lower end of the mass. We are using, it's a very magnified image actually. We are using most of the otological instrument here. If you see the cup forceps, and it looks like we are doing a surgery in a 60-year-old man, but it's not. It's a 6-month-old child, and that's how we have cleared all the remaining portion of the. This is the iris scissor we use for micro surgery. And adrenaline was used to prevent if there's any bleeding. And this is how you can see there's almost total removal of the tumor, and we have extubated the cell on the next day. And tracheostomy was closed. So we have put the cuff of the endothecal tube on the operative side, and we have extubated the cell. And this was just immediate post-op. That's all from my today's presentation. Thank you, sir. Thank you so much.
What was the biopsy of this swelling?
Hematoma. Hematoma.
You did it really well. I must congratulate you. It needs a lot of guts to do that, and you did it quite well.
Thank you. Thank you, sir.
Great video, Bishwajit. Congratulations.
Thank you.
That was a nice video.
If there's any comment about the tracheal mass, we will take it. Otherwise, we'll go to the questions straight away because we are already running.
Already late. Yes.
Yeah, Sanchita, can you come in?
Yes, sir.
There were 2 questions from the last session. We'll just go to those and then we'll come to today's questions.
Okay, sir. So there's actually one question and the other one is a comment. Dr. Shruti Dhingra, madam, is asking, in case of a large lingual thyroid without normal thyroid in neck, and the child is in stridor due to the cyst, would it be possible to partially resect the lingual thyroid? And which instrument is the best in that case?
Lingual thyroid are the most dangerous ones to operate when you're doing on the base trunk. A valvular cyst is the easiest one.
Yes.
And the only thing you don't want to put is a collator band blindly inside the lingual thyroid because they bleed like anything. But of all the instruments, coblation is the best possible instrument to it, and partial excision is accepted. But more often you'll be able to totally remove it if you are slow in the surgery. And in your settings, you are giving a lot of saline washes for the coblator to work.
Thank you.
To this question, Dr. Thiruna Vukarasu, he had replied, it is a non-functional thyroid with hypothyroid, so can be excised and give thyroxine supplement lifelong.
Yeah, actually that is the best strategy to do, because in these cases the thyroid is not usually functional, and maybe if it is functional, usually the patient is hypothyroid. So it's better to remove everything, and coblation is the, I think, tool which works the best in the given situation to remove the lingual thyroid.
Excellent. Can we go to the next question?
Yeah. Yes, sir. From the first talk, the first question is from Dr. S.B. Fukon, sir. He is asking, is there any chance of recurrence of laryngeal web? And do you put steroid or anything of the like post-incision?
We haven't put steroid in our cases. we just followed them up. But steroid have been advocated by other people, as Dr. Shashi had also pointed out. And would any of the experts come in on that? Your personal experiences on web?
Chances of webs are always there.
Yeah,
Obviously,
they are always try to come back.
and
So after, yes, Shashi, please.
how do you reduce is your, so you have to decide the duration of the stent.
Yes.
If the scarring is too much, the thickness is quite a bit of thing, then you have to put the stent more than 3 weeks. And if it's a simple, like what Dr. Rakesh laser web was there, you probably don't even have to put a stent. You're better off before the stent. Maximum duration which you want to keep is 3 months. And after that, the complications will rise tremendously. Even if you are putting a stent there, you have to revisit the patient every 2 to 3 weeks and kind of recheck it, the granulation tissue, or flush it with antibiotic and other things. So if you're doing all those things, the restenosis rates decrease.
Yeah, you might end up getting a very small web, which may not
Yes.
matter regarding
We also give steroid nebulization at home for these patients.
when you
Steroid and ciprofloxacin nebulization for these
if you
patients.
have a very small web, it hardly matters. For elderly sort of when we have done, we used to call them after say 1 month, 3 weeks, and under sedation or GA, we used to clean off the slough that was there. We used to do that earlier, but you don't get that many cases to say that we have been doing this routinely. Or next, please.
Yes. Dr. Reshmi M. Nair ma'am is asking, how do you stabilize the stent or keel? This question is to Dr. Shashidhar's presentation.
How do you?
In response to your presentation, first of all, she has said that this is an excellent idea, and she is asking, how do you sterilize the stent or keel?
Sterilize.
That's how it goes. ETO. So the CSD team which we have, they does a ETO and sends it off. So after you do the cut and everything, you give them back the bag and they will ETO it and send you back.
And Dr. Pradeep Kumar Tiwari is asking, when do you remove the keel?
Minimum duration which I want to keep is 3 weeks. So we get a lot of international patients. They are in a hurry to go up. So maximal I compromise is to put it 2 weeks. But there's no point in putting a stent if you're keeping it less than 2 weeks actually.
Moving ahead, Dr. Shambhunath Mukherjee's comment that formation of granulation affects results and that repeated balloon dilatation might be helpful. There's also a comment from Dr. Thirunavukarasu. He's saying you can also use Tor's round knife.
We can use?
Tor's round knife.
Round knife.
Round knife, yeah.
That's a good idea.
He's also, yes.
Yeah, Dr. Raman wants to say something. No.
Yes.
I want to ask a question to Arpit. Arpit, that semicircular knife, the needle for the cleft. I have the Store's semicircular one. It's like a cobbler's needle. Is that the one you're talking about?
No, sir, that was the Vicryl stitch only, 5/4 Vicryl with the half needle.
Usually 3/4, it's a half.
Oh, okay.
Half circle.
No, I thought you were talking about one. Store's instrument is there. It's a long needle, which is semicircular. Okay.
5/4 Vicryl with a half circle.
The one artist code actually was a needle without the eye. It's a on needle.
That is a different Listenberger needle. So that's, I think sir is asking about today's laryngeal cleft.
Cleft. The thing is that I think it requires a handle. We've got it without the handle, so it doesn't reach. So I don't know. I'll have to check out from somebody who's got a similar needle. So I thought I'll check out with you.
Okay. Next question is from Dr. S.B. Fukon, sir. He's asking what other congenital abnormality can be associated with laryngeal web?
Laryngeal web usually exists with subglottic stenosis. That is the commonest thing. Then I talked about the chromosomal abnormality where you can have one of the syndromes which was shown there.
Charge and digeorgia, if I remember correctly. Chart syndrome and Digeorge. These are the
Charge is there, yes.
Can we move ahead with the question, sir?
Yeah, please.
This is from the second talk, congenital laryngeal cleft. This question is to Dr. Bishwajit Gogoi, sir. Dr. Nitesho Singh is asking, do you suture the cartilage too during cleft surgery?
No. Don't suture the cartilage. That's why you require optimum posterior mucosa, so that you can have a end-on, and that means the philosophy is that the mucosa should not be too tight. So we have in the OT actually we have a war with the pediatric surgeons. So give me more mucosa towards, don't take towards the esophagus. Give me more towards me, because let's the airway first, then you food pipe.
Okay. Next question is from Dr. Kudush Ahmed, sir. He's asking, how did you manage the post-op feeding in the type 3 cleft patient?
Jejunostomy, that's what he said, right?
Post-op feeding.
Post-op feeding. Try to avoid Rayleigh tube.
Basically,
Fed or
sir wants to know whether you have done a jejunostomy or
gastrostomy.
Feeding gastrostomy. Because Rayleigh tube we should avoid it, because both the wall is there, the new mucosal wall is there. So there's every chances of any refistula. So we should avoid the Rayleigh tube.
Okay. Moving ahead to the next question. This is from Dr. Nitesho Singh, sir. He's asking, why not to search for the RLN nerve? I think it's always better to identify and preserve it.
Sansita, mind it, it's a 15 days old child. It's a 15 days old child. Definitely, since I am not getting proper pretracheal fossa, that's why I am searching for the nerve. Basically, if you go for tracheal skeletonization, it does not require to searching for the nerve in I don't know what my CCA and RPT will have a comment on regarding searching on the recurrent laryngeal nerve in tracheoplasty or tracheal reconstruction. But generally, definitely in this case, since I'm not getting proper tracheoesophageal groove, so my first idea is let's don't have a vocal cord palsy if I make a good airway also. But if you have a bilateral palsy, cord palsy, and if you there's no enough airway due to palsy, so I'm taking microscope. I have searched in my video most fully. I can appreciate both the right and left side of the recurrent laryngeal nerve. That's always a
recurrent laryngeal nerve is like God. You fear from it, but you don't see him.
Exactly.
Even if you have to do a slight tracheoplasty where the whole trachea and esophagus are complete,
and if you take a microscope, you definitely will find it.
Yeah. Next.
Okay, quite a lot of compliments coming your way, Dr. Bishwajit, sir. Dr. S.B. Fukon, sir, Dr. Kalpana Sharma, ma'am, Dr. Pradeep Kumar Tiwari, Dr. P.V. Ellen Murthy, sir, Dr. Shambhunath Mukherjee, sir, they are all complimenting you regarding the type 3 cleft surgery.
Thank you.
Absolutely fantastic.
Then Dr. Pradeep Kumar Tiwari is asking, what was the size of the tube for intubation?
50 years old baby. I have two options, 2 or 2.5. It was 2.5.
The next question is from Dr. P.V. Ellen Murthy, sir. He's asking, in 2-layer suturing, which layer has to be dealt first, laryngeal or esophageal? Now, to that question, Dr. Thiruna Bukarasu has replied that it is laryngeal.
Exactly, because it's always come first. A's always come first. Yeah.
Now, questions from the third talk, laryngotracheal stenosis. Dr. P.V. Ellen Murthy sir is asking, actually he's commenting, excellent conclave of airway stenosis. Then again, compliment from Dr. Pradeep Kumar Tiwari that it's a very good presentation. Then Dr. P.V. Ellen Murthy sir has requested Dr. Shashidhar some elaboration on the suprastomal tracheomalacia ballooning. Is it done with a bigger sized balloon, or do you overinflate than the diameter?
Excellent question. So there were 3 ways to solve this. One is to go and do a resection anastomosis, which is the most morbid way of doing it. Second what Cincinnati does is they just intubate the child with a suprastomal collapse and keep it for a week and remove it and then suture the ends. For some reason, it works. But for us to take that risk that for 1 week you're going to intubate the child in ICU is just the other part. In between, somewhere balance, you kind of use a balloon and you kind of use exactly the age appropriate lumen size only. You don't go for an oversize. But if you see the balloon is slipping, then you have to, like I said, I kind of put patties in between the balloon and the wall. So it kind of tells me if the balloon is loose or tight. So it adjusts to the size on its own. So using patties with a balloon is one of the easiest things which helps you sizing. And since patties are collapsible, it never does too much of harm also. And I've used patties with mitomycin, steroids, so many other things with the balloon because they also act as a medium for dissipating the drug inside the tissue also.
One of the cases that we had, Biswajit, you remember, we had put in a T tube and let the child grow, because with growth the size of the trachea increased, and we could take out the Montgomery the T tube.
Exactly, sir.
Shashi, is there something known as suprastomal stents also for such situations?
Well, all these stents are usually suprastomal only because
Yeah.
by nature. But the stent which you're saying, if it's integrated with the tracheostomy tube, that was the Albuquerque original stent, where the stent was attached to the tracheostomy tube, and it kind of comes as the upper limb, just like a T tube, but not as soft as a T tube, but like a stent.
Great Ormond Street for a long time was using the
Dumont
tracheostomy
stent.
tube with a hole and the conventional ET tube on top, and it goes and just fits onto the tracheostomy tube. That was an improvised thing those days, the old one.
Oh, yeah.
Sanchita, please, next.
So actually, last question. This is from Dr. S.B. Pukon, sir. He's in relation to the tracheal mass presentation, he's asking, is this the case published in the Annals of Otolaryngology? I think the tracheal mass, Vishwajit Gogoi sir had demonstrated.
Yeah. It was published in Annals of Otolaryngology.
So about the last case, one of the good instruments to try that would be a skimmer actually to take it. We had 2 or 3 such of swelling, and we were lucky that one had a pedicle, and I used a tonsillar snare for it, and I was so excited to show that the tonsillar snare can also work inside the trachea. So that's one way place where we use the snare, and skimmer and coblation used in combination with each other. But looking at the 6 months age and all the things, what he did is absolutely fantastic. I'd just say it, really good job and
It
very
depends on
courageous of him to do it.
Yeah, it depends on where the lesion is, how inferior the lesion is, and the age of the baby.
And that too without a ECMO or a CTVS support. If you're expediting going into that region, that really
Exactly.
needs a lot of time.
So see, when I've searched the literature for the tracheal mass now, then I have found most of the cases they did in a cardiomyopathy bypass or bypass, because issue was with the ventilation of the child. If you have low tracheal mass, if you can't ventilate the lower airway, then that's just. But definitely there will be bleeding. Definitely the lower airway will be swelled. So you have to guard the lower airway. That's the biggest challenge.
That has multiple problems. You can't infiltrate that mass because
because the baby vascular, because we have no pure biopsy.
You're already a low on saturation, so you can't suck out much blood also.
Actually, what happened is, Dr. Sachi, we had an adult patient with a tracheal mass, and we did this maneuver because the patient had gone into respiratory difficulty, and we had
basically collapse.
The patient had collapsed absolutely. So when we did that, we got the idea, and when we got the child, say, okay, this worked. So that's how we actually got into it.
With the coblation, I think the struggle would have been little lesser. what you did was a very good thing, but with the coagulation, if it would have been available, the struggle would have been little lesser. So
My
whatever,
repeat issue was that the 6-month trial, and that is not a good body weight. That was not a good body weight because of long-standing his disease. So that's why we have a very narrow space. I have a 4 scope. So I always take the scope and all this for recording.
I've
you're a very brave surgeon.
guts. I've seen similar passes in adults being done by pulmonologists using the cryo machine.
Yeah.
And that
Most
works
probably
pretty well. Cryo and
in Kashikombakotam Hospital, Thiru has experience with laser, with fiber optic.
but not at
I don't
6
know.
months.
I don't know exactly.
Touch with a pulmonologist. Nobody would touch.
We'll be hearing from Dr. Thiru on Sunday. Yeah, his experience. He's been working in the pediatric hospital, so he has got a lot of experience. So, if Sanchita, there are no more questions.
No, sir. No more questions, sir.
I would like to thank Dr. Sashidhar and
Thank you, sir. It's an honor to be here.
Yeah, that was a great discussion, great learning from all of you. Thank you very much.
Welcome you to
Thank you, Samitra, for your presence. Thank you, Shashi.
Thank
Thank
you
you all
very
the
much.
panelists.
Thank you very
Sir,
much.
thank you always.
So good night,
Raman,
everybody.
sir.
Thank you. And Arpit, see you tomorrow.
So Deepa is also there, sir. Deepa, I think Deepa is there.
She's got a 10 minutes deliberation on ultrasound of the trachea.
Tomorrow.
Tomorrow, when you are speaking on radiology, the last talk is radiology. So at that time, she has got a 10 minutes presentation.
Thank you so much, sir.
Thank you
so
very
much
much.
for
Thank
giving
you
me
very
this
much.
part. I'll be prepared for that.
Okay, sure.
Thank you.
Thank you, sir.
Thank you. Good night, everybody. Good night.
Good night.
Everyone, good night.
Good night. Good night.
Thank you.
For
Thank you.
watching.
Bye.
Thank you, people who have logged in.